I'm unable to hear anything. I am unable to listen anything.
Mention. Good morning. I, Kanika Jain, nursing officer from emergency medicine.
And I, Abhishek Nahar, Nursing Officer, Department of Hospital Administration.
Welcome, respected director, sir, chief medical superintendent, sir, medical superintendent, sir, chief nursing officer, ma'am, deputy nursing superintendent, ma'am, esteemed faculty members, and distinguished guests, nursing officers, students, and all participants joining us today. It is my privilege and honor to welcome you all to this international nursing webinar organized by the Nursing Administration SGPGI Lucknow in celebration of International Nurses Day 2026. International Nurses Day is celebrated on May 12 every year to honor the dedication, compassion, and hard work of nurses across the world. Nurses play a vital role in promoting health, care, caring for patients, and supporting families. During difficult times, the 2026 themes are Nurses, Our Future. Empowered Nurses Save Lives highlights the importance of supporting and strengthening the nursing profession for a healthier future. This day also marks the birth anniversary of Florence Nightingale, whose contributions transformed nursing into a respected profession. This year's themes reminds us of the strength, compassion, resilience, and dedication that nurses brings to healthcare every single day. Nurses are not only caregivers but also educators, leaders, researchers, and the backbone of healthcare system. Their commitment towards patient care continues to inspire hope and healing in society. Today's webinar is a platform to recognize the invaluable contribution of nurses and to discuss the evolving role of nursing in advancing quality healthcare services. I'm confident that insightful sessions and discussions planned for today will motivate all of us professionally and personally. On behalf of the organizing committee, I extend my heartfelt gratitude to our respected dignitaries and speakers and participants for gracing this occasion with your presence. With great respect and warm regards, I once again welcome you all and wish the webinar a grand success. First of all, I extend a heartfelt welcome to our respected director, Professor Dr. R.K. Dhiman, sir. Your visionary leadership, guidance, and continuous support towards excellence in healthcare and education inspires us all. We are truly honored by your gracious presence today. I would also like to warmly welcome our respected Chief Medical Superintendent, Professor Dr. Devendra Gupta, sir. Sir, your dedication and commitment towards strengthening patient care, services, and hospital administration are deeply appreciated by all of us. A very warm welcome to our respected Medical Superintendent Professor Dr. R. Harshvardhan, sir. Sir, your valuable contribution and encouragement towards maintaining quality healthcare services continue to motivate the entire healthcare team. I extend my sincere respect and warm welcome our respected Chief Nursing Officer, ma'am, Mrs. Manju Singh, ma'am. Ma'am, your leadership, guidance, and unwavering support towards the nursing fraternity and truly inspiring for all nursing professionals and students. Now, I would like to respectfully invite.
Now, with the blessings and gracious presence of our respected dignitaries, we shall formally proceed towards the inaugural session for today's webinar. Before we begin the webinar, I would like Ms. Mamta to please felicitate our guest of honor, Ms. Neelam Srivastav, ma'am, Assistant Nursing Superintendent at SGPGI Lucknow. I would now invite Ms. Ansi Jairaj, ma'am, to kindly come on the dais, and Ms. Yasmin to please felicitate ma'am. I now invite Ms. Neema Pan, ma'am, Assistant Nursing Superintendent at SGPGI Lucknow on the dais, and Ms. Mamta to please felicitate ma'am. Thank you, ma'am. Now, to commence the program, I feel privileged to invite Ms. Neelam Srivastav, ma'am, Assistant Nursing Superintendent at SGPGI Lucknow, for the opening remarks. Ma'am has been a pillar of nursing leadership and administration, continuously improving the nursing professionals toward academic excellence and quality patient care. Ma'am, I kindly request you to address the gathering.
Thank you. Good morning to all respected dignitaries, esteemed speakers, and dear nursing professionals. Greeting to all the esteemed speakers, dignitaries, and nursing professionals. It is a pleasure for the organizing committee to extend a hearty greeting to all the attendees of our International Nursing webinar, as well as our esteemed Director Sir, CMS Sir, and MS Sir, as well as all the prominent speakers. We are thrilled to have such a motivating group of nurses that are dedicated of the nurses that are dedicated to improving their skills. These Nurses Day celebration is greatly enhanced by your attendance today. We would like to express our sincere gratitude to everyone who attend this important session and our presenters for sharing their knowledge. I hope everyone will find this webinar interesting, educational, and enriching. Once more thanks you and heartily welcome to you all. Thank you.
Thank you, ma'am, for your motivating and insightful opening remarks. Your words have truly set a positive tone for today's academic event. It is now my honor to invite Ms. Ansi Jairaj, ma'am, Deputy Nursing Superintendent at SGPGIMS Lucknow, to deliver the welcome note. Ma'am, your dedication towards nursing administration and professional development continues to inspire many nursing professionals like ourselves and students alike. Kindly address the gathering, ma'am.
Good morning, everyone. It is a pleasure for the organizing to extend the heartily greeting to all the attendees of our International Nursing webinar, as well as our esteemed directors are CMSR, MSR, and CNO ma'am also. We are grateful to have such a motivating group of nurses that are dedicated to improving their skills. This Nurses Day week celebration is greatly enhanced by your attendance today. We would like to express our sincere gratitude everyone attended in the important section and our presenters for sharing their knowledge. I hope everyone will be find webinar interesting, educational, and enriching. Once more, thank you and thank you. Heartily welcome to all.
Thank you so much, ma'am, for your warm and gracious welcome note. Your encouraging words and thoughtful address have truly made everyone feel welcome and inspired.
Now, I respectfully invite our esteemed guest of honor, Ms. Neema Pan, ma'am, Assistant Nursing Superintendent at SGPJMS Lucknow, to address the audience.
पर हाँ कुछ हमारे सशक्त सिपाही थे उनके बगैर हम सरलता की कल्पना नहीं कर सकते सबसे बात बोलिए आपने कभी आप लोगों से पता की एग्जाम पर इससे ज्यादा ऐसा टीचर जो सोचता है कि उनके सामने उसका टीचर मंच बन तो मेरी सीधत के लिए चाहती हूँ प्यारे पहलू का हमेशा मेरा बेटी का को करने का नहीं जब कहीं को देखती हूँ कि क्या वो देखकर पूछे चाहे हमेशा हाथ करके जाने के लिए तब ये और तो मैं सोचती हूँ कि इतना बात से आप कहाँ से लेकर आते हैं चाहे मैं अगर चाहे इसका नाम ना पूरा होना एकदम स्टैंड होना और पूरे अस्पताल के होना दूसरी बात ये बिना से आप देखेंगे कि हमारे भीतर पूरे विश्व से हमारे शरीर देंगे इस खूबसूरत सोच के लिए थैंक यू आप आपकी मर्जी से धन्यवाद देना चाहती हूँ अपने दोस्तों का भी और आप सब दोनों बहुत अच्छे एंकर हैं बिल्कुल बहुत अच्छा लगा कि आप लोगों ने हमारा स्वागत किया है जिससे मेरे प्यारे साथी कॉलेज से आप लोग आए हैं आप सबको मेरा सलाम फिर आपको धन्यवाद जय
Thank you, ma'am, for addressing the audience. Your words are truly encouraging and enlightening. Thank you, ma'am.
Now, we shall begin the scientific session of today's International Nursing webinar. We are privileged to have eminent speakers from our different esteemed institutions, sharing their expertise and experience on evidence-based nursing practice.
Before moving on to the scientific sessions, we have with us our Chief Nursing Officer, ma'am. So I would like Miss Mamta to please felicitate ma'am. I would request our CNO ma'am to kindly come on the dais and Miss Mamta to please felicitate ma'am.
कोई नहीं मैं बिल्कुल तो जाएगा
Thank you so much, ma'am, for gracing the occasion. We'll now begin with the scientific session.
So let us begin our scientific session. It is my privilege to introduce our first speaker, Professor Dr. Uma Rani Adhikari, ma'am, Principal of Government College of Nursing School, Burdwan Medical College and Hospital, West Bengal. Dr. Adhikari, ma'am, holds a PhD and MSc in nursing from AIIMS, Delhi, New Delhi, along with a diploma in cardiovascular and thoracic nursing. She brings over 30 years of combined clinical teaching and administration experience. She has published 50 plus research articles and a textbook. She also has served as an editorial board member and journal reviewer. She worked as the INC ad hoc inspector and expert from Nursing Research Society of India. She also served as master trainer for HIV/AIDS and bioethics programs. Today, she will speak on strategies to support evidence-based practice in nursing.
Over to you, ma'am. Start.
Is it audible?
Yes, ma'am.
Hello?
Yes,
My
ma'am.
screen is able to see? Screen is visible?
Yes, ma'am.
Yes, ma'am.
Okay, thank you very much. First of all, good morning, all the dignitaries, presenters, administrators, staff, and everyone present here. And I would like to thank the organizer for giving me the opportunity to speak in this platform. And my topic for today's presentation is evidence strategies to support the evidence-based practice in nursing. Actually, nowadays, nursing practice is undergoing tremendous changes in order to meet the social challenges and needs. Evidence-based practice is essential for improving patient care, but it can be challenging. Here, I would like to highlight few strategies to enhance the evidence-based practice into nursing, that is in clinical nursing practice and nursing education. First application of evidence-based practice is to clinical nursing practice. Number one strategy is education and training. Attending continued nursing education, that is workshop, seminar and online courses to keep the healthcare professional up to date with the latest research, and all the healthcare personnel should engage themselves in journal clubs. Through mentorship also, evidence-based practice can be practiced in the clinical area. Number two, clinical guidelines and protocols. Clinical guidelines and protocols should be based on latest standard research. Administrators should ensure that these guidelines and protocols are accessible and easy to use. Number three, interdisciplinary collaboration. Foster collaboration between researcher, clinician, and other healthcare professionals to bridge the gap between research and practice. Encourage nurses to participate evidence-based research network and where they can contribute to and apply research directly into the clinical settings. Number four is clinical decision support tools. Integration of research in electronic health record, decision support tools and mobile application. Embed evidence-based recommendation within the electronic health record to guide the clinical decision at the point of care. Number five is quality improvement initiatives. Regularly test new evidence-based practice through pilot program before wide-scale implementation. Regularly auditing practice and provide feedback to ensure adherence to evidence-based guidelines. Number six, leadership and organizational support. Utilize or designate clinical champions or change agents who are responsible for providing and supporting the application of research in practice. develop policies that prioritize the use of evidence-based practice within the organization, and administrators should ensure that research application is a part of the institutional culture and allocate time for nurses to review and integrate research into their clinical practice. Next, number 7 is patient involvement. Involve patient in the decision-making process, ensure that they are informed about the latest research and its integration into for the further care. Provide educational material and resources to the patient also. Then only you can implement evidence-based practice, as because patient is a component of providing this evidence-based practice. So patient's choice is very, very important. Next, number 8 is overcoming barrier. Addressing knowledge gap, time management, and dedicated time for research application. Identify and address any gaps in knowledge and skill among clinicians which may hinder the application of research. Number 9 is monitoring and evaluation. Regularly measures patients' outcome to assess the impact of research application on clinical practice. Use outcome data to continuously refine and improve the integration of research into practice. Next, sustained research practice integration. Maintain interdisciplinary team meeting that regularly review and discuss research findings and their application in clinical practice. Promote a mindset of adaptability where the clinicians are open to new research findings and utilize to adjust. Incentives and recognition. Offer incentives such as professional recognition for clinicians who effectively integrate research into the practice. Regularly celebrate and publicize success where research application has led to improved patient outcome and reinforcing the value of sustained research integration. Next, application of the evidence-based practice into nursing education. Number 1 is curriculum integration. Actually, integration into the curriculum which is already integrated, but research and clinical rotation should be implemented from diploma course onwards. Next is faculty development. Opportunity should be given to the faculties to update their knowledge so that they can guide the students and staff to implement evidence-based practice. Next is clinical partnership. Develop strong partnership with clinical setting which allow students and staffs to participate in research activities. Number 4 is the use of technology. Use simulation labs to conduct research studies basically for the novice researcher, and provide access to online research database and tools and teaching them how to find, how to appraise and apply evidence in clinical scenario. Number 5 is evidence-based teaching strategies. Case-based learning and implement flipped classroom model where the student review research article or evidence guideline before entering into the class, and they can then apply, and they have learned through discussion activities in the classroom. Next, research culture and environment. Create a culture that value and practice research within nursing program, and by celebrating research achievement and integration research discussion into regular academic clinical activities. Evaluation and feedback. Regularly evaluate student research competencies through assessment and test their ability to understand and apply research. And next, encouraging lifelong learning. Instill the importance of lifelong learning and lifelong learning of research as a professional responsibility for nurses, and engage alumni in on ongoing research and evidence-based initiatives. Next and last is the Nursing Research Committee, setting up a committee in hospital to encourage research collaboration and implementation support. All should consider research is a professional responsibility for nurses. Next, the take-home message: we need to conduct very high quality research, that is meta-analysis and systematic review before implementing the evidence-based practice, and we have to consider this high standard of research into the evidence-based practice. Next, research findings should be communicated and that are in user-friendly manner. Next, empowering role models, employing nurses and research skills. Next, need adequate training, information and opportunities for implementing evidence-based practice. Proper time and dedicated time for research application is very, very important, because most of the cases, barriers of implementing this evidence-based practice is lack of time. Next is ongoing and collaborative learning is very, very important. Emphasizing research regarding research driven promotion and career development, means in every recruitment, research actually should get the priority in education as well as for recruiting staff nurses where they are working in the clinical field. Next, faculty and staff education through continued nursing education, journal club and mentorship program is mandatory. Actually, using collaborative model as a method could facilitate research utilization in order to improve the quality of nursing care as a whole. Actually, this collaborative model is the dual role of nursing, which is most commonly referred to the integration of nursing education and clinical service, where a nurse simultaneously acts both as a clinical practitioner and educator. This model is designed to bridge the gap between the theoretical knowledge which is taught in the classroom and practical which is taught in the bedside application, and ensures high quality patient care and training. So with this, I thank you all. Thank you everybody. And before that, just I want to say in advance, happy Nurses Day to all the nurses present here. Thank you once again. Hello. I have completed my presentation. Is there any questions? Hello, am I audible?
Yes, ma'am.
Yes. Is there any question?
I think no questions, ma'am.
Okay. Then thank you. Thank you very much for your patience hearing.
Thank you, ma'am, for such an enlightening and academically enriching presentation. Your insights regarding the integration of evidence-based nursing into nursing practice will certainly inspire all nursing professionals towards research-oriented patient care.
Our next distinguished speaker is Professor Dr. S. Balabani Bose, ma'am, Principal Government College of Nursing, LLRM Medical College, Meerut. With over 22 years of teaching experience, she has guided numerous postgraduate dissertations, published 25 plus research articles, including Scopus index papers, served as CNE Observer and CNPD Committee Chairperson, received recognition from the Honorable Chief Minister of Uttar Pradesh for academic excellence. She will present on role of evidence-based practice in improving patient safety and quality care. Ma'am, we are honored to have you.
Good morning, all, and thank you so much for giving this opportunity. So now we'll go for the presentation. Hope my slide is visible. Could any one of you tell me whether my slide is visible?
Yes, ma'am.
Okay, thank you so much. So the topic is role of evidence-based practice, improving patient safety and quality care. So this itself is a sea-like information, like so many informations, like what the medical care and nursing previously it was and what it is now. That itself will show the development, and the trends will show the importance of the evidence-based practice in each area. So nothing is possible without applying any informations or any practices based on evidence-based. Whereas only few areas that I'm going to touch in this webinar. So let's go with that. Evidence-based practice integrates the best available evidence, clinical expertise, patient preferences to guide the healthcare decisions. It plays a critical role in enhancing patient safety. Second, somewhere it is. Healthcare decisions, it plays a critical role in enhancing patient safety and delivering high quality care by minimizing errors, standardizing procedures, and improving outcomes. So, importance of evidence-based practice in patient safety and quality care. It promotes standardized clinical protocols. It reduces variability in care. It enhances clinical decision making, and it minimizes risk and adverse events. It improves patients' outcomes and satisfaction and encourages accountability and transparency in healthcare. So only few areas that we are going to see in quality care, because evidence-based practices spread everywhere. And this small webinar, it will not be possible for me to cover all the areas. So only few things. One is, first is fall prevention. So according to the statistics, the falls is comprising of the most dangerous quality related issues in hospital care previously. Whereas this falls prevention are the major causes of morbidity, especially among hospitalized and elderly patients. And it has been informed through the studies from Indian Territory Hospitals report, especially approximately 2 to 6 falls per 1,000 patient days it is happening. 1,000 patient days means it is an admitted days. So the factors influencing or factors related to the falls include patient related factors, which is intrinsic. It includes age and physical conditions like elderly, muscle weakness, poor balance, and poor gait problems, and medical conditions like confusion, delirium, dementia, stroke, Parkinsonism, orthostatic hypotension, visual impairment, cataract, blurred vision, etc. And the medications like sedatives, sleeping pills, antihypertensive, diuretics, and multiple drug increasing the risk. And the next point is mobility issues like use of walking aids, like crutch walking, where they are using improperly, post-surgery weakness, fatigue, dizziness, etc. So these are the patient care or patient-related factors called intrinsic. And the next one is extrinsic factors, which is hospital or environmental factors. It includes bed or furniture, like high bed height, absence of side rails, unstable chairs or stretchers, or without the lock facilities, and the surroundings including poor lighting, slippery or wet floors, cluttered rooms or obstacles, etc. Toileting issues, lack of assistance while going to bathroom, urgency, incontinence, and even lack of supportive devices inside the washroom areas like hand bar, all these things. Equipment and devices, those factors include IV lines, catheters, drains, which is restricting the movement, and improper footwear like loose slippers or slippery bottomed slippers, all this. And the next factors include staff or system factors, inadequate supervision, inadequate staffing that comprise most of the faults because as per the Indian scenario, we are ending with or we are facing so much of issues in inadequate staffing related. And we are always facing even in the corporate, starting from the corporate, even till the low level, like inadequate staffing is the main important problem. Poor risk assessment, lack of patient education, delayed response to call bells, inadequate documentation, inadequate communication, etc. And the situational factors include nighttime, first ambulation after surgery, change in medication or condition. So all these are the factors. So in this fall, what type of role that the evidence-based practice may do is that the first is use of validated fall risk assessment tools. There are so many fall risk assessment tools, example, Morse fall scale. Like, first of all, being a nurse, we should understand who are at most risk for having the fall while that they are admitted. So when this fall risk assessment tool is applied, all the patients, so the score will be showing you whether the patient is at fault, and at least the preventive actions could be taken in a well advanced manner. And implementation of multifactorial interventions, like based on the fall risk interventions. Fall risk assessment. Environmental safety modifications, patient and caregiver education. So all this can be done in evidence-based practice interventions. So the evidence-based interventions include regular risk assessment, bed alarms, non-slippery footwear, adequate lighting, and clutter-free environment, supervised ambulation, which may impact on reduction in fall incidences and decreased injury rates and improved patient confidence and mobility. So this is regarding fall. And the next one is medication errors. This is another widespread area where maximum mistakes or errors are happening in the hospital or clinical setting. So the thing is, medication errors are preventable. That is the main thing that we need to concentrate. Since it is preventable, that we need to concentrate more. Since it leads to a serious harm. Medication errors can lead to unpleasant consequences such as prolonged hospitalization, increased treatment costs, and even sometimes death. So medication error, it may lead to incorrect transcription, mix-up of patients, mix-up of drugs, mistakes in calculation of drug concentration, incorrect or missing labeling solutions, wrong omitted past expiry date. These are the types of medication errors that it may happen. Difficulties in handling certain IV preparation or techniques, and incomplete delivery. Incomplete delivery of the container or contents, incorrect infusion and absorption mistakes and incompatibilities, insufficient mixing of ingredients, wrong storage, contamination of solutions, use of inappropriate diluents, incorrect transcription. So these are the types of medication errors which may happen or which is already happening in clinical settings, which compromises the quality patient care. According to WHO, medication error occurs in following stages: prescribing approximately 21.3%, transcription 1.4%, dispensing 15.9%, and administration 54.4%, and monitoring 7%. So when this all is, when you observe this particular statistic, the administration errors are more rather than any other areas or errors. And role of evidence-based practice, hope I'm continuously audible. Is there any issues? Can I get my voice checked? Am I audible? Can I get my voice checked? Am I audible?
Yes, ma'am.
Okay, thank you so much. Thank you. So the role of evidence-based practice in medication error, including but not concealing with the adoption of the rights of medications administration. Again, the number of rights, it is every year it is increasing. When it's like previously it was 6 and then 7, and even the patient's rights have been also included. So completely the nurse, each and every nurse should be aware of the patient's rights and the medication's rights, which is evolving concurrently over years. And you have to follow the rights of medication administration, use of clinical guidelines and protocols, and integration of technology like electronic prescribing and all. There are so many things that already have happened in terms of medication errors. Like we have got the drug policy, drug return policy, and how it has to be written. Everything it has come. The clinical guidelines and protocols and double time checking and all these things. And evidence-based practice interventions include, but not it is the final one. There are n number of evidence-based intervention which is prevalent already among the clinical areas, including SGPGI, to improvise the quality care. Medication reconciliation, barcode medication administration, double check systems for high risk drugs, and staff training and competency assessment. Everything it is available. So only one example I would tell you, like, medication administration. A patient was, for the pain, a patient was prescribed for injection Oviron, like diclofenac sodium. So the nurse was, not much experienced, whereas a 3 ml of injection diclofenac sodium, she has administered bolus IV, which really had hampered the life of the patient, and we had so much of troublesome in reviving the patient. The real thing is the bolus injection of diclofenac sodium should never be administered in IV, whereas only IM is the prescribed mode. But if it has to be given IV, it has to be slow or this one. So maximum it is not been advised. Whereas and this causes hypotension. If the training and if the experience is not happening, or even not consulting with the senior members even before administration of, we can call it as even smaller low level injections also, like antipyretics also, it may end with the patient's life. So this requires the clean adoption of the evidence-based interventions, and training is most important. And also one more issue for the medication error is long shift duties and extra shift duties, which that the nurse administrators may think of having, is because we are all human beings, and there are so many possibilities for a nurse, being a human being, to make mistakes based on the physical and constraints and all that. So like we have so much to talk about this medication errors. We may do it maybe in the next seminars. And when this evidence-based practice and medication errors are being followed, it impacts or it results in reduced or adverse drug events, improvised medication accuracy, and enhanced patient safety. And the third one important thing that I'm given with is like infection prevention. So another area where there used to say, like all our people used to say, like I go to the hospital with the A problem, the disease A, and they will donate me disease B. It's a hospital acquired infections are more nowadays, and especially the all the even superbugs have come. So the superbugs are the one where already, and it is based on the drug antibiotic policy and also over the counter drug. So here the infection prevention is more important, and it is especially in the hands of the healthcare professionals, that is cross infection and the iatrogenic infections. So infection prevention refers to the measures and practices used to reduce the risk of transmission of infectious agents and protect patients, healthcare workers, and the community. So here the role of evidence-based practice include implementation of standard infection control guidelines, use of scientifically proven hygiene practices, all this. So evidence-based practice, evidence-based interventions, few are hand hygiene. So the basic hand hygiene technique, which is 7-step technique of WHO, like it has to be performed where we underestimate the hand hygiene techniques to be the real life scenario, the ground level scenario is that we always underestimate the hand hygiene. When it is being followed, it is being said that 50% of the infection stops get transmitted when the meticulous hand hygiene techniques is followed as per the protocol, whereas that need to be strengthened among the hospital care providers, including the class 4 workers. Use of personal protective equipment, standardization and disinfection protocol, and personal protective equipments, we are not in a proper way. Like see, cap we wear, especially the caps are the cap has been given only like prevention of hair fall or even hair follicular infections and all those things. But when we just wear the cap, automatically already the hair is visible and hair comes outside the cap, which makes incompetent wearing of the personal protective equipment, which in turn causes the infection transmission. Sterilization and disinfection protocols, antibiotic stewardship programs, all these things. When these are being followed, it reduces infection rates, it lowers hospital stay duration, and it decreases the healthcare costs, and the patient care quality will be sure increased. And the next one is documentation. So clear-cut documentation is more important. So that is a saying. There is a saying regarding documentation that you do and you don't document, it is equal to you have not done. So here documentation is more important and for the patient care because it transfers or it transmits the information from one staff to the another staff, where either the duplication errors will not happen, as well the negligence also will not happen. So importance of documentation, like clinical documentation, it builds patients engagement, trust, provides patients medical history, improves service deliveries, staff efficacy, eases billing, reimbursement, ensures legal and regulatory compliances, and it reduces risk and exposure. Like all, there are so many n number of documentation importances. The role of evidence-based practice in documentation, standardization of document practices, use of electronic health records, and ensuring legal and ethical compliances. So evidence-based interventions for documentation include timely and accurate charting, use of standardized terminologies like clear communication among healthcare team members. So whatever the format or standardized terminology is only used in your areas or else are applicable and approvable in throughout the community, and that only have to be utilized, which impacts on improve continuity of care, reduced communication errors, and enhanced legal protection. So here, in improving the quality of patient care, if you ask me, madam, only if these 4 areas are concentrated, will it be final? No, there are biomedical waste management, which we are having evidence-based practices, and starting from even admissions, and transferring of the patients, each medical nursing procedures, everywhere the evidence-based practices that we need to adapt. But only these are the common areas which we need to think about. And what are the challenges in implementing evidence-based practice in clinical setting? It includes lack of time, lack of resources. We don't have time either to look back to the evidence-based practices, what are available in our area. And for those particular evidence-based practices, like we are not having the adequate resources and resistance to change. This is the major issue which is prevalent among our nursing community, to be very clear. Like we never try to change. Even the even now the senior nurses are telling to the junior nurses, once upon our time we used to do like that, long ago, like we used to follow this, why are you doing this? See, here the problem is that the resistance to change and incapability to adapt to the newer technologies. So these both are making the junior nurses or the upcoming nurses to have a dilemma whether to follow the old which is there in the book, or whether to adapt to the new which is there prevalent and has been shown or proven through the evidence base. So these things, I think nursing community can little come forward to clear all these things and try or accept the changes and subject ourselves to change without changing the philosophy. Limited access to research, and research, we just think that only the academicians own the research, whereas the nurse administrator should encourage the nursing research among the clinical practitioners also. And inadequate training and strategies to promote evidence-based practice, continuous education and training, even in the clinical setup, so as each clinical nurse will involve in the research related, institutional support and leadership, access to research databases, and encouraging the culture of inquiry. So, like as a conclusion, evidence-based practice is fundamental to improving patient safety and ensuring quality care. By applying research-driven interventions in areas such as false prevention, medication safety, infection control, and documentation. But they are some examples, but it is not completely concerned with this. Healthcare professionals can significantly reduce risk and enhance patient outcomes. Strengthening EBP adaptation is essential for advancing modern healthcare system. So with this, I thank the organizing team for giving me this opportunity and wishing you an advanced International Nurses Day. Strengthening yourself is very great, and strengthening your community is more important. And thank you so much once again. Over to you, sir.
Thank you, ma'am. Thank you for your highly informative presentation. Your discussion on patient safety, infection prevention, medication safety, and quality care beautifully highlighted the practical significance of evidence-based nursing. Now I cordially invite Alka Mohan ma'am, Deputy Nursing Superintendent, Nurani ma'am, Deputy Nursing Superintendent ma'am, to kindly join our members on desk. Our next esteemed speaker is Professor Dr. Rajalakshmi Mishra ma'am, Principal College of Nursing, Behrampur, Odisha. Ma'am completed her post-graduation from RK College of Nursing, New Delhi, and obtained her PhD under Behrampur University. She has extensive experience in clinical nursing, teaching, administration, and postgraduate research guidance. She currently serves as Dean Nursing under Odisha University of Health Sciences and has worked as member of various academic and government committees. Ma'am has guided more than 200 postgraduate students in research and has also served as resource faculty at PGI MER Chandigarh. Today, Ma'am will speak on clinical nursing practice guided by evidence. Ma'am, we are honored to have you with us.
Thank you for the introduction. First of all, I wish you all a happy Nurses Week. Yeah, I'm very thankful for the organizing committee for giving me this opportunity to say before you on ABP. So first of all, we were listening to all the speakers on ABP. And what are the components, if you'll go to the definition of evidence-based practice or the clinical nurses, we need to involve in research and establish the evidences to integrate into the practice. Three components are highly important. One is external evidence of high quality research. So when you are conducting research of randomized controlled trial or any intervention based research that you just see you out of your expertise and experience, the committee who is there in the hospital for uh, I mean implementing these evidences, they need to see the patient preferences and expectation and whether this evidences is applicable or for the patient or doing without doing any harm. So these all components are highly important. As I said, external evidences from research, then clinical expertise and experience of the individuals who are conducting the research and going to implement these evidences, and how you are putting the patient values and giving importance to the patient autonomy and preferences and expectations. As I was going through all the research topics, is almost everything is being given to all the speakers. So I didn't want to highlight those areas which has been allotted to other speakers. But some of the things I'll highlight on the implementation because this part I think very lightly, even though my previous speaker has said about some areas like fall risk and the about the medication error, all that. So I wanted to how you'll implement the evidence-based practice. First of all, you have to, do this. Remember this 5A. What the is all 5A stands for this acronym. A stands for Ask the Focused Clinicalness question. Usually, being the educators, we are always take example of our students into every topic or when you give examples, we involve our students. I'll just invite all the nurses of SGPGI Lakshno. Just they need to involve in all research work. Beyond your working hours, you give 1 or 2 hours for research, clinical research. And it is the part of management. They need to give all support to the nurses so that they can to have their continuing in nursing education department. When you are seeing the clinical nurses are coming with these seminars and conclaves on different educational topics, it's really praiseworthy. It's really praiseworthy for their work. And I used to invite all the nurses who were present over here. They should engage themselves in clinical research now from today onwards because it's very important. What are the issues and problems and the challenges you are encountering during your clinical practice? That will give you idea how you'll solve it. So you raise the question in your clinical site, that a research question on which you will conduct a study and you will solve your problem. So that database, when you do these small researches and high quality researches by using these randomized control methods and also other intervention-based studies, that database will help you to use those evidences with all the discussion with all, as madam, all speakers said about the collaborative approach. With the collaboration of all the department, with the decision of all the experts from different departments, you can utilize those evidences. So it is the call for the clinical nurses to be engaged in research, clinical research. So they need to generate the research, topics or questions while they're encountering different problems, issues, and challenges in the clinical area. Then they need to acquire the relevant evidences. When you complete the study, you just place the evidences what you collect before the committee, if you have. Then those relevant evidences that has to be appraised. That means that has to be criticized by the experts, whether that is a qualitative findings which can be applicable in the practice or not. So next is appraise the quality of the applicability, quality and applicability of the findings. That is very important. Then when you have a checklist and you appraise, evaluate the study findings, whether it is applicable or whether it is doing any harm to the patient from all angles. When you appraise that research findings, then you go for applying this into the practice and see the outcomes. It has been seen the evidence which when it is used in clinical practice, it has reduces the mortality and complications. Studies have shown when this evidence-based practice in hospital has been implemented, the mortality and major complications has been dropped significantly. So this is very important to know for the nurses that they have to, why they need to engage in the research. Then also when you implement these findings, that shortens findings. Those who are in clinical practice, I'll just highlight what are the findings. We have already, the evidences have been integrated into the practice after this. Then it will shorten the hospital stage and lowers the readmission. So the relapsing period has been dropped, reduced, and the readmission has been declined when the evidence has been integrated into the practice. I'll give an example. All the guidelines, protocols, what you're using now in the clinical practice, those are nothing but the evidences from different researches has been integrated into the practice. Then also it increased the patient safety, as madam said about the previous speaker about the medication error. How the simple task of look alike and sound alike arrangement of the drugs help you to reduce the medication error. So that was the essence of doing the research and using the evidences. So what is the role of nurse leaders in implementation of ABP? They have to foster an adaptive leadership, and they have to give uh, resources, supply the resources or allocate the resources for all the staffs. So the nurses who are beyond their office hour, giving 1 or 2 hours for the research work, they need to be supported by the management and also workflow design. See, when you are doing any practice, for example, if you are using the defibrillator, if the work instruction or whatever the tests you are doing or whatever the procedures you are doing, if the work instructions are there, I think if you have written that work instruction stepwise, or the workflow is maintained, written there, that means the newcomers who comes for the practice also, the errors will be reduced if workload designs are there in every aspect or every procedure, for every task. So that is what it is very important. Users do these standards or maintain these protocols. Automatically, the errors will be reduced and patient safety will be enhanced. And obviously, you are going to give the quality care to the patient. Then overcome the barriers. I think all the different, speakers, they will highlight on the barriers while using the evidence-based practice. So I am not going to that aspect. So these are all these trainings after these uses of evidences. These trainings have been on EVP has been given. This is when we see the use of BAP bundle and central line care bundles, sepsis bundles. All these we have seen the reducing the errors of medication error, reducing the chances of injury, reducing the infection. So this training has been integrated into the nurses practice. I'll just highlight some of the examples of these clinical practices, like preventing hospital acquired infection using the different kinds of bundle, as I said, central line care bundles, and these hand hygiene protocols, you keep it in mandatory. All these minimizes the chances of infection. Then pressure ulcer, wound ulcer, when you just use the Braden scales, all that to assess the ulcer and take the preventive measures. So it reduces the chance of pressure ulcers among the chronic patients. And my previous speaker also said about the false prevention, when we just for that how we were taking care of, and also the medication safety and chronic diseases management, like my previous speaker highlighted the use of double check high alert drugs and all that techniques. So these are very helpful for, in clinical practice. These evidences have been included, and if you are practicing those standards and protocols and the guidelines, I think we are reducing the mortality, morbidity of the patients in the hospital. Then I'll just highlight some of the evidences which has been integrated in midwifery, and government of India is taking that steps to produce more of midwives. So now the midwives are using all the evidences what you are seeing, the mothers are being delivered by all different alternative positions, like all four, lotus bath, all these squatting, which was not used in our practice. Previously we are only using lithotomy position for delivering a mother. So that is what these have been included, that it has been seen. If you use this alternative position, the complications are less, and you need to not to do the deliberate, episiotomy, all that. So this is how we are protecting the patient, and we are preventing the mortality and morbidity of the patient. So that is very important. So I just invite all the nurses. This is a key message for all the nurses who are present over here, to foster a culture of spirit of culture of doing the researches, and the management has has to extend the support for the nurses, and those who are being involved, some incentives to encourage the nurses beyond their office hour, 1 or 2 hours they need to engage themselves in the research work, so that we can get more of evidences in the hospitals, and that will help us to solve all the issues and problems and challenges which we are facing in the hospital. So thank you all once again. I am giving, I wish advance happy Nurses Day to all. And thank you once again to the organizing committee for giving me this opportunity. Thank you. Over to you, sir.
Thank you, ma'am, for sharing your valuable expertise. Your presentation beautifully emphasized the importance of integrating scientific evidence into day-to-day clinical nursing practice. Now, I cordially invite Kalavati ma'am and Aditya Kumari ma'am, Assistant Nursing Superintendent, to kindly join the members on desk. Thank you, ma'am. It is now my pleasure to invite Mrs. Shabana Khatun, ma'am, Associate Professor, College of Nursing, SGPGI Lucknow. Ma'am is a PhD nursing scholar with more than 16 years of teaching experience. She has served as acting principal at the College of Nursing, SGPGIMS, and has also worked as examination coordinator, NAC nodal officer, SNA advisor, and assistant program coordinator for community health nursing programs. She has delivered lectures for Pan-African programs and has contributed through publications in national and international journals. Today, ma'am will deliver her session on From Research to Bedside, Applying Evidence in Daily Nursing Practice. Ma'am, kindly proceed.
Good morning, everyone. Myself, Shabana Khatun, Associate Professor, College of Nursing. And I would like to thank the organizing team, the nursing administration of SGPGIMS Lucknow, for organizing the international webinar on the occasion of Nurses Week. So let's start with my topic. So today my topic on From Research to Bedside, Applying Evidence in Daily Nursing Practice, Translating the Guidelines into the Routine Care. So as we know that what is the evidence? So using evidences, what do you mean by research to bedside? We are using the evidences from research to improve the real patient care treatment and their care. Okay, whatever we are doing on the patient, whatever evidence care, that is based on evidences, and evidences we are getting from the research. So translating the guidelines, that is evidence based in routine care of the patient, and these guidelines were given by some of the organizations like WHO, World Health Organizations, or the Center for Disease Control and Prevention. So these guidelines are adopting by them, and that can be given as a protocol or guidelines, and that the nurses using in their while they are providing care to the patients. So where the word come evidence-based practice first in nursing. So the Florence Nightingale's book Notes on Nursing, that is in year 1850, she has given the concept of evidence-based nursing practice. So evidence-based nursing practice, I think this already taken by the previous speakers. So just I'm briefing it. It's provide nursing care that use the most current research, whatever the evidences which are recent, which is help the patient improve their outcome, that can be, we can use as a evidence on patient care. So that is high quality patient care we are delivering, so that reduce the healthcare cost and improve the patient outcome. So that can be integrate into the clinical nursing practice. If we'll see what is research in nursing and evidence-based practice in nursing. Evidence means not just a research. So there is a difference in both the word. So research means that is we are just validating the existing nursing knowledge or the theories we are having in hand. And we are generating new knowledge which we are using for the patient care. While evidence-based practice, we are taking the most appropriate evidences which we are taking from this as a stamp from the nursing research, or we can say that research which we are take the consent of the patient and take care of the patient in the hospital setting. So if we'll see the process, how the research go to the bedside as evidence. So research studies, first we are conducting and getting the evidences, which is scientifically proved. Okay, that is implementing with so many clinical trials, random like RCT programs, like meta-analysis, like so many type of studies we are doing on the patient and getting the evidences which is scientifically proved, and these evidences we are converting into the guidelines, that is called evidence-based guidelines, that is given by WHO or hospital protocols. They have their own guidelines. So for that we are getting the guidelines, then we have to, our responsibility to train the nursing officers. So they should understand and train the nursing officers to understand the guidelines. So if they understand the guidelines, they can able to take the clinical decisions. And clinical decisions, they can use the evidences, they can improve their skills, and they can also understand the patient needs. And patient needs, it depends upon the PICO. PICO means patient problem. Okay, whatever the problem, like the patient with the liver cirrhosis. Then interventions, like for example, we are doing the one taking the patient who are prone to bed sores. That is a patient, and intervention like repositioning of the patients. And C is comparison, wherein we are not doing the repositioning of the patients and outcome. So we are assessing whether the patient getting the good outcome, improved, or prevent the pressure sores with repositioning is good, or we are not turning the patient and we are doing the repositioning of the patient every shift hour or shift duties. Okay, so the outcome may be vary in the both the groups, intervention and comparison group. So then we are getting the guideline, understand the guidelines, trained from the guidelines, so we can implement on daily nursing care while medications, maintaining hygiene of the patient, and repositioning of the patients, etc. So we are getting the patient outcome in terms of their improvement, in terms of their safety and the recovery, and getting discharged from the hospital. So for this process, it is not a stop here. We need continuous feedback, and there is a continuous chance of improvements. So we'll see what guidelines affects the patient and healthcare system. Whatever we are since morning, you are looking the evidence-based practice. So how it's effect on the patient and how it's effect on the hospital and how it's effects on the nurses also. So outcome, like for the patient outcome may be improved. Okay, so shared decision making should be taken and used best research evidences, which is we are not using traditional ones, and the patient also satisfied from that evidence-based care. And patient autonomy should be also keep in mind. And if we will discuss about the healthcare system, so the cost of healthcare may be reduced because the patient recover fast, the resources demands may be reduced also. In terms of nurses practice, how the nursing practice improved by evidence-based practice. So that is, first one is decision-making skills, because they are using the scientifically proved evidences, and hence their critical thinking use, or they can update their knowledge with new evidences, and they can also encourage themselves lifelong learning. So we will take some examples how we are translate the evidence-based practice in patient care, in daily routine care. So for example, a simple step like the patient who are in the bed, they are bedridden. We can elevate the patient head end 30 to 40 degree by doing a simple thing. We have to prevent so many complications, like we can prevent the ventilator associated pneumonia. Will raise the patient head end 30 to 40 degree of angle. So these, we are not like we are having the evidences and we are just implementing on the patient. It is not like that. We should follow the guidelines which is given by some organization, some society, some hospital protocols and manuals are there. That is why all the nurses are using, all the nursing officers are using it, not vary from one patient to another patient. So for example, this one, that is Center for Disease Control and Prevention Health Infection Control Practice Advisory Committee, they have recommended that is 30 to 45 head elevation prevent the ventilator associated pneumonia. So one study was conducted, so many studies, and from these studies we are getting the evidences. That is why we are implementing on the patient. So one study, that is supine versus semi-recumbent position in ventilated patient, and it was found that the patients who are in supine position, they have higher incidence of the ventilator associated pneumonia versus the patient who are in semi-recumbent position. They are significant improvement, or they have reduced the ventilator associated pneumonia if their the head end increased, elevated 30 to 40 degree of angle. Then this is second example to reduce the pressure source. Okay, so just turning and repositioning of the patient every 2 hourly. 2 hourly करने में ज़्यादा better है. If we are doing in the 4 hourly, there is a chance of developing pressure source. So if we can do in 2 hourly, like these are given by the guidelines, these are international guidelines. National Pressure Injury Advisory Panel 2019, they have recommended repositioning of the patient, especially the bedridden patients, risk assessment of the pressure source, support surfaces, especially bony prominence of the patients, and skin care of the patients. We are doing as a nursing officers, as a nursing students, you are doing in the hospital setting. So these supported by the Cochrane evidences. In 2020, they have done one review, Cochrane review, that is repositioning for preventing the pressure ulcer in the adult patient. Next example, to improve the infection control practices. So many guidelines are available to reduce the infection and to prevent the hospital associated infection to the patients. And how, like WHO and CDC guidelines, they have given through proper hand hygiene, using protective personal equipments, use aseptic techniques, sterilizations, and isolation precautions. These, if we are follow while taking care of the patient in the daily routine care, that can be reduced. We can reduce the hospital acquired infection to the patient. So one study, that is a cluster randomized trial, Bennett 2015, they have done one study for reduction of health care associated infection by improving the hand hygiene in the patients. So in that program, they have done one training program, that is the hand hygiene program. In that training, monitoring, and feedback to assess how to reduce the hospital acquired infections if the patient follow the guidelines of WHO, and just doing simple thing, that is hand washing. So this is another example for the chronic obstructive pulmonary disease patients, that is COPD. So that international guidelines of chronic obstructive lung disease 2023 to 2024, they have recommended if we maintain the oxygen saturation of the COPD patient from 88 to 92% and give the oxygen therapy and assess their ABG, we have to prevent the patient hypoxia, the patient who are in the in the oxygen therapy, to prevent their hypoxia, and their survival rate also increase among the COPD patients. Next example, I am taking the urinary tract infection. Okay, that can be prevented if we are avoid unwanted catheterization of the patient to prevent this. Okay, so that is catheter associated urinary tract infection. These can be occur if we are doing the catheterization of the patient. For that, there are the guidelines which is evidence based. Center for Disease Control and Prevention guidelines for prevention of clotting. There are so many bundle cares are available to prevent the infections, UTI, respiratory infections, and other catheter-induced infections. So like they have given, use catheter only if appropriate indicated. Then while if it is not avoided, the patient need to be catheterized. So for that, we have to maintain the aseptic technique while insertion of catheter. Then close drainage system to prevent the infection spread, and remove the catheter as soon as possible. As the patient feel the sensation on the bladder key, they can able to eliminate the urination by their own. So avoid unnecessary catheterization. So this I am supporting with one evidence study, that is Sanjay Sant et al. 2000. There is a the topic is of this study is risk factors for catheter associated UTI. So there is a in this study that was in their finding, the 3 to 7% there is a chance of infections or UTI if the per day if the patient is in catheterized. Okay, so early removal is critical to prevent the infection. So we try to avoid the catheterization of the patient. So this is all about my topic. So that is take home message. Evidence-based practice is a bridge between research and the real patient care. So whatever we are providing care to the patient, that is evidence-based, have the protocols, have the guidelines given by some organizations, have in the hospital manuals. So that guidelines we are equally giving to the all the patients, so they also reduce the chance of variation of the patient outcome. Okay, SNEA we are giving one care to the one patient, so another care to the another patient, so there will be variation. So guidelines help us to give direction how to take care of the patient in daily routine while you are taking care of the patient in the hospital setting or in the clinical setting as well. So we have to train the nurses. They should understand or integrate the evidences, and they should also keep the patient preferences in mind and their outcomes, what improvements they have, and that should be like whatever care we are providing, it should be patient centered. So this is all about my topic, how the evidences will go from the research to the bedside, how we are using the guidelines and taking care of the patient in daily routine care. Thank you once again.
Thank you, ma'am, for such a practical and inspiring session. Your presentation effectively demonstrated how evidence-based guidelines can be translated into routine nursing care for better patient outcomes. Now I cordially invite Jyoti ma'am, Sunil Kumar sir, and Pratibha ma'am, Assistant Nursing Superintendent, to kindly join us on this desk. It is now my privilege to invite Professor Dr. Shampa Gupta ma'am, Principal College and School College of Nursing, Narayana Hospital, Howrah. Ma'am possesses over 25 years of rich professional experience in nursing service, nursing administration, and nursing education. She has worked in various capacities from staff nurse to nursing director and presently serves as principal at Narayana Hospital. Ma'am is also an AHA instructor for BLS and ACLS and has contributed significantly through nursing research publications and academic activities. Today, ma'am will share her expertise on evidence-based study on intravenous pain approach and methods. Ma'am, we warmly welcome you.
Thank you. Am I audible? Am I audible?
Yes, ma'am. Yes, ma'am, you are audible.
Just let me share. Share. Just a minute, I can't share. I don't know why. Is my slides visible?
Ma'am, the slides are visible, ma'am, but can you please make it to full screen, ma'am?
Trying. Is this visible? Is this
Ma'am, it's visible,
this
but
okay?
ma'am, it's too small, ma'am. If you can make it go full screen, ma'am, or open.
Actually, I am not getting these things. Actually, it is only coming through the mail. I am unable to access the desktop. I don't know why. It is there in the.
Okay, ma'am. If it's visible to the audience, ma'am, we can proceed like this only, ma'am.
Just let me just try once because this is very difficult. It will be.
Excuse me. Can you choose this third icon that is showing slideshow down?
Means I am unable to recognize the slide. If I am sending to WhatsApp, can you share?
Yes, ma'am, you can send it on WhatsApp, ma'am.
Okay, I'm just sending in the WhatsApp. That will be better because I can't see the slides.
We'll do it from here, ma'am.
That's better. Just give me 1 minute, please. Please tell me the mail address. It's not going to WhatsApp also, some server issue. Do you just tell me the mail address? I don't know what is the problem.
Ma'am, we have shared the email address on your WhatsApp, ma'am.
I have sent WhatsApp also the to the doing. I've also WhatsApp the things to the doing also. Here server issue. Actually, I'm not in my office. That's another problem.
उसी लड़की को दे दे.
I have already said.
Yes, ma'am, we have received the PPT, ma'am. It's taking some time, ma'am. The presentation will begin in a moment.
Okay. Actually, where I am here, this is some server issues are there. That is the reason another problem.
This meeting is being recorded.
You may start, ma'am.
Okay, but I can't see anything. Okay, fine. Now I got it. But can I operate, or you have?
Ma'am, I will operate for you.
Okay, just come to the next slides. Okay. A very good morning. Extremely sorry for the technical glitch. Now, to begin with that, it is very quite obvious that it is easier to find men who will volunteer to die than to find those who are willing to endure pain with patience. And as we are the nurse, it is our responsibility to give the comfort, to ease the pain of the patient. Next slide, please. To ease the pain of the patients for every aspects. And when our patients are coming inside the ward in patients, and the most common procedure which is giving pain to the patient, that is what? That is the intravenous IV line access and intravenous therapy. Now, why this is very painful? It is not just only because of the pricking. It can, next slide please. It can, so it is the most commonly preferred sites. It's very deep, and it is causing different type of complications like phlebitis, infiltration, extravanation, cellulitis. All those things will be there because of this intravenous therapy. And this intravenous therapy is very common. It is not an uncommon procedure. So there are so many evidence-based practice and evidence-based studies are there to control the pain in intravenous pain and approach. Now coming to one by one. What's next? So these are the pain which we are assessing. So this is the evidence base, like we are assessing pain by asking or by checking your behavior or the facial expressions. So there are different tools are there, standardized tools are there to assess the pain, which is already evidence. Next slide. So because of this pain is actually a significant barrier. So many times we are telling, no, it should be later, not now. And this pain is called as a needle phobia. Next, needle phobia, what is happening? When there is a needle phobia, there is a vasovagal reflex reaction, which initially increase the blood pressure and then decrease the blood pressure, which may eventually can cause to the death. Next, so our most important aspects is use evidence-based practice to relieve the pain. So what is this evidence-based practice? This is a conscientious, explicit, and judicious use of current-based evidence in making decisions about the care of an individual patients. Next. It is the process by which clinical decisions are taken using the best available clinical evidence from expertise and patient preference. So when we are talking about the intravenous access, intravenous pain approach, there are many issues are there. One is technical, another is technological, pharmacological, and non-pharmacological. All these components can be utilized as a evidence-based practice. Next, please. Initially start to the technical skill. Now when the technical skill, we are using the different type of vein for intravenous cannula insertion. So in a purposive randomized study, it has been seen, next please, antecubital fossa is the less painful site for venous cannulation in comparison to dorsum of the hands. Mostly we are using the dorsum, but it is very painful. But if you are using an antecubital fossa for the pricking and for the IV line, it is less painful. Another one, next. So there is the effect of communication on pain during intravenous cannulation. A randomized control trial telling, so many times what we are telling, okay, now we are going to prick you, there will be a stinging sensation. So we are making the patients aware that we are going to cannulate the patient. But study shows that warning patients of a sting before IV cannulation may not be helpful. So to someone it is effective, to someone it's not effective. So after the technical, there is a technological components. Coming one by one. Next, so this is the trans-illuminated thing facilities which facilitate the venous cannulation in infant and small children. So with the light which uniformly illuminates the superficial tissues inside the ring, because of that deoxygenated blood in veins absorb the light, so veins show as dark lines within the illuminated area, and it facilitates the cannulation. Placing the gentle pressure on the vein light stretches the skin and engorges the vein for easier needle insertion through the opening in the ring. This is a very practical, evidence-based practice for easy ventilation and the reduced sensation. Now the VEID adapter, which consists of a pressure sensor, a signal processor, and a signal indicator, which combined into a pocket-sized lightweight unit, which attaches to the proximal end of any standard IV cannula via the disposable VEID adapter. Now the pressure sensor, what it does, it reacts to pressure changes at the tip of the cannula. The processor immediately, which within 0.1 second, activates a beeping signal that it reaches actually to the vein. So it is very effective for cannulation and reduction of the pain. Next, please. Now, ultrasound guided peripheral IV placement, which is very common practice when there is a complex when the brain is visible. So, evidence is that if you are going for ultrasound guidance, it gives a very good result. So, there is chances of another pricking or multiple pricking is very less if we are using the ultrasound peripheral IV placement. Next, please. Next, please. It, it reduces the need for a central line and its potential complications. Now, another one that is light-based devices. So, what these devices does, light which can be either absorbed, also can find veins up to the 0.4 inches deep. In fine detail mode, the contrast is boosted so that it shows the best place of the, and so that it can penetrate the skin and inject the needle. So easy. So this type of devices is used when there is a tortuous vein, very delicate vein, the patient is in a collapsing state. So when we are using all these things, so it is a very good approach for the IV site cannulation as well as the controlling the pain. So it will reduce the multiple pricking. Next. After the technical and technological, there is a pharmacological evidence. Study shows that the pain during venous cannulation, if you're using the topical amethocine or the mixture of local anesthetic, both are giving the same effect. Next. Same thing if you are using this type of cryogenic and all. So it is a fast active hypocoolant we spray. It also giving the good effect for minor invasive procedures. Next, there are different type of devices, that is the laser assisted topical anesthesia and IV insertion pain. The study says, so when we are using these things, so only for the difficult cases, laser enhance uptake the topical numbing agent and decrease the pain of the IV cannulation. Another nitrous oxide, which is the effective type of concentration of the nitrous oxide to reduce the peripunctal pain only in the children. Nitrous oxide has rapid onset and both analgesic and mild sedative effects and decrease the pain associated with the IV cannulation. What the study reports. So this is the evidence. Now coming to the non-pharmacological approach, there are many non-pharmacological approaches there, like sucrose. Many studies shows that sucrose for analgesia in newborn infants undergoing painful procedure. So if you are administrating oral sucrose, like 0.5 to 2 ml up to 12 to 50% solution, 2 minutes prior to the single hill lance is effective in providing pain relief in both terms as well as the preterm infants. So it is practiced in many of the organization as evidence-based practice. Very common practice like parental holding. parental holding and positioning to decrease the IV distress in younger children. Many study as well as a randomized control prove that parental holding and upright positioning appear to be a successful in reducing the distress of having an IV started in young children. And the effect of another evidence-based practice, the effect of combined stimulation of external cold and vibration during immunization on pain and anxiety also reduces the children. So when you are stimulating the skin with the ice and all and some vibrating devices, it reduces the pain. And which is used in the pediatric immunization. This is the budge. Next, effect of voice therapy on the visibility and palpability of the peripheral veins. Also, there are a lot of evidence, especially the patients who are undergoing chemotherapy. So, it is a significant effect on the visibility and palpability of the peripheral veins with the application of moist heat at the site of prior to peripheral intravenous cannulation. But we have to maintain the infection control. Effect of Valsalva maneuver prior to peripheral intravenous cannulation and intensity of pain also very good. And there are different studies published that Valsalva maneuver performed before venous cannulation decrease the intensity of the pain. Music therapy, a very common established evidence-based practice which has a significant place in treating pediatric procedural pain. Now, another one thing is there for the adolescent or adult child, like health play personal cinema system. It is a distraction tool that is acceptable to most children and can contribute towards satisfaction of the intravenous cannulation process. So they will be focusing on this particular personal cinema, forgetting about the prick and all. Next. Some other non-pharmacological, just before the like your guided imagery, your music therapy, your therapeutic touch, your deep breath, all these are the evidence which is having some good effect for distracting a person while cannulating the patients. So the movement is less, patient's anxiety is less. All those distraction therapy also can be used as a evidence-based practice while cannulating a patient. Next, please. Now, what is the benefit? Why we are using the evidence-based practice? So, the benefits of evidence-based practice are multifactorial. It is cost effective. Having evidence, we are confident. Yes, it is efficacy. There is efficacy. It's cost effective. We can go on. Now, there are certain conditions which is necessary for the evidence-based practice. We have to have the availability of the evidence. We have to scrutinize critically that the evidence are applicable in our setup. The conversion of that evidence has to be done in the applied form, because what is applicable in the Indian scenario may not be applicable in the abroad, or what is applicable in the abroad may not be applicable for the Indian. What is applicable for the adult may not be applicable for the pediatric, and the vice versa. So we have to convert the evidence into an applied form. The acceptance of the evidence as legitimate and is used as the basis for change in managerial or clinical practice. The nurse practice to implement changes based on evidence. Evidence-based decisions are made actually after reviewing information from repeated rigorous data gathering, and you have to gather instead of relying on the rules. Single observation or custom. You are getting only one study and you are thinking, yes, it is right, and you are going to apply. No, it should not be like that. You have to come for evidence-based practice after rigorous data gathering on different aspects and coming to conclusions. Next. Certain challenges for the evidence-based practice, that is our cultural challenges, introduction challenges, implementation challenges, many areas educational gap, or our experience gap, prior So less. So these are the common challenges what you face when we are going to implement the evidence-based practice. Next, please. And some other challenges also, like lack of knowledge, skills, lack of attitude, lack of confidence, lack of time, lack of support, lack of resource, lack of coordination, organization. All are the challenges which you have to every day face. So how to overcome? Everything there is a solution. When there is a problem, there is a solution. So you have to follow the ABCs of EBP. What is A? A for ask. Ask what is the problem. B, books. Books means not the book. Book means review of literature. Find out all the different of study, what is published, scholarly published, non-scholarly, everything you see. Consider which is applicable for you. Develop according to your setup and everybody's acceptance. Evaluate how it is effective in your setup, and then you facilitate. That's the basis of evidence-based practice. Next. So at the end, what we can say, let whoever is in charge keep this simple question in our mind, that not how can I always do this right thing myself, but how can I provide for this right thing to be always done. And that's the evidence. If you're doing something good, it is effective, it should not be isolated for you. It should be disseminated properly in the forum so that everyone can take that evidence and practice in the clinical setup. And that's the beauty of the evidence-based practice and benefit for the patients. And with this, I'm ending over here. Thank you.
Special thank you, ma'am, for the excellent presentation. And you managed to present this presentation in a very short span of time, and managed and agreed with Juin ma'am and gave an excellent presentation. So thank you so much for this presentation.
Thank you.
Now I cordially invite Bimlesh Kumar ma'am, Manju Singh ma'am, and Kusum Khan ma'am, Assistant Nursing Superintendent, for kindly joining us on our desk.
For the next scientific session, we have a respected speaker, Dr. Anjana Bala Behrwa ma'am from SSB College of Nursing, Odisha. Ma'am completed her PhD from JGTU, Rajasthan. Ma'am holds a MSc Nursing from Medical Surgical Nursing for Berhampur University. Ma'am has a combined experience of almost 3 decades in the teaching and clinical domains. Today, ma'am will address the topic on challenges and opportunities in implementing evidence-based nursing. Ma'am, we kindly request you to enlighten us with your valuable thoughts.
Okay. Good afternoon, everyone. Good morning, everyone. Am I audible?
Yes, ma'am, you are audible, ma'am.
Yes, sir.
Okay. Is there my PPT is visible or not?
Yes, ma'am, the PPTs are visible.
Is there? Okay. Good morning, all the dignitaries present over here. My topic is challenges and opportunities in implementing evidence-based nursing practice. The main focus on barriers in clinical setting and solution. Evidence-based nursing practice emphasizes on best evidence, patient references, and clinical expertise, which helps in improved patient outcome, enhanced patient safety, better clinical decision making, professional growth, and quality healthcare and cost effective. Evidence-based nursing practice is an important approach in the modern healthcare. It helps nurses provide safe, effective, and quality patient care. Evidence-based combines research evidence, clinical experience, and patient preferences. It improves decision-making and patient outcomes. It reduces the medical errors and promotes professional nursing standards. Despite its benefits, its implementation it helps in clinical setting which faces several challenges and barriers. The main definition of evidence-based practice is it is a process of making clinical nursing decisions using the best available research evidence, clinical expertise of healthcare professionals, and patient needs, values, and preferences. Evidence-based nursing practice is a method of patient care by using the latest research, nursing experience, and patient preference to achieve the healthcare outcomes. The importance of evidence-based nursing practices are mainly it improves patient safety, reduce the medical errors, enhance the quality of care, promotes professional accountability, encourages the continuous learning, increases the patient satisfaction. The best example is using infection control protocols based on the current research which reduces the hospital acquired infections. The main challenges or barriers in the clinical settings are main focus. Most of the resource persons were discussed about that. The main focus on this is lack of time. Due to the lack of time, nurses often having workload, long shift duties, and staff shortage. This leaves little time to read research articles, attend training, and applying new evidence in the practices. The main effects are depends on the routine or outdated practice, which reduces the quality improvement in the activities. The main solutions are allocate the protected time for research and learning, reduce unnecessary documentation burdens, and use quick evidence summaries and clinical guidelines. Then limited access to resources. The limited resource approach to resources are some hospitals has lack internal access, journals, and a database library services. The nurses cannot obtain the updated evidence. So there should be provide access to online database and hospital libraries. use mobile apps and digital resources, and collaborate with the academic institutions such as nearby the institutions which provides the training and participates in the different procedures like that. Then inadequate knowledge of research method. Due to inadequate knowledge, many of the nurses may not be trained in research methods, critical appraisals of the studies. Then uh, the main effect is difficulty in understanding the research findings and low confidence in applying the evidence. The main solution should be conduct workshops and continuing nursing education programs. Nowadays, so many programs are continuing in the government of India and the state government and all the colleges and nursing institutions are providing the trainings like that. The nurses should participate in the training program and include evidence-based nursing practice training in the institutions. Then provide mentorship program from the experienced nurses or educators. Resistance to change. There is some of the people are having resistance not to change their mind setup. Some healthcare professionals prefer traditional methods and may resist adopting new practice. As for the effect is slow implementation of improved care method, which conflicts among healthcare team members. The main solution should be encourage a positive learning culture, involve staffs in decision making, demonstrate benefits of evidence-based practice through successful examples. And then heavy workload and staff shortage. In most of the hospitals, many of the hospitals are having the shortage of staffs. Due to shortage of staffs, what happened? And the nurses should focus mainly on immediate patient care. They are not involved in any research activities or any research or any training activities. So less participation in research activities occur. The main solutions are improve nurse-patient ratio, recruit and retain adequate staffs in the hospital, and use teamwork and delegate effectively. Then lack of organizational support. There are in the sometimes in the hospital we are not getting the supports from the administrative and not getting the supports from the higher authorities, and without support from the difficult. So lack of funding, training or resource are available, and it affects the low motivation among the nurses. The main solution is leadership should promote evidence-based practice, and it provides financial and educational support and create evidence-based practice in the committees. Then lack of proper leadership and mentoring due to improper communication and collaboration. What happens in between the team members and doctors and nurses? There is some problems occurs in hospital, and insufficient patient care occurs and delays in applying evidence solution. The main solutions, it promotes interdisciplinary teamwork and conduct regular meeting and decision, and improve communication skills. Okay, next. Lack of time. Barriers are lack of time, limited access to research resources, inadequate knowledge of research method, resistance to change, heavy workload and staff shortage. Already I have discussed about this, and a lack of organizational support and poor leadership and mentoring. Then lack of time, which problems nurses often have busy schedules, long shift, emergency responsibilities. This leaves little time to read research articles, attending training, implement new practices. The impact is continued use of outdated methods, reduce motivation in the care. Then limited knowledge and skills, which creates the problems some nurses may struggle with, and understanding research articles, data interpretations, critical appraisals of evidence, which causes insufficient evidence practice education, lack of training workshop, and it impacts on difficult in applying evidence in real clinical situations. Then organizational and cultural resilience, which creates the problems. Healthcare institutions may resist change to because of traditional practices, fear of new methods, lack of leadership support. Main examples are senior staff performing old routines, poor teamwork in implementing protocols, and the result slow adaptation of evidence practice intervention. And organizational and cultural resistance. The main problems are healthcare institutions may resist change because of traditional practice, fear of new methods, lack of leadership support, and a senior staffs performing old opportunities, poor teamwork in implementing protocols, and a slow adaptation of evidence-based intervention. Then solutions to overcome barriers are effective strategies, education and training, conduct evidence-based workshops, include evidence-based in nursing curriculum, administrative support should be there, leadership and mentorship should be there, then provides access to journals or database, allocate time for research activities, encourage nurse leadership to guide the staff, promote teamwork and communication, use digital role of nurse in promoting evidence-based practice. Nurses should stay updated with current research practices in training programs, collaborate with healthcare team, and advocate for patient-centered care. Encourage a cultural of learning. The opportunities in evidence-based nursing practices are improved patient outcomes, which helps to provide safer, more effective and quality care. It benefits to reduce complications and infection, faster recovery, and increased patient satisfaction. Then professional development. Nurses gain critical thinking skills, research knowledge, greater confidence in decision making, and a better healthcare qualities. Hospital using evidence-based practice often achieves standardized care, improved safety, better clinical efficiency. It is also cost-effective care. Evidence practice interventions reduce unnecessary treatments, unnecessary hospital staying, and healthcare expenses. It increased patient satisfaction. When patient receives evidence-based care and the proven method and their proportional preference, and it also strengthens nursing, increases credibility and
Ma'am, please unmute yourself, ma'am.
organizational support, leadership, and use of technology. Overall, evidence-based practice plays a vital role in improving nursing practice and healthcare quality. Thank you all. This is all about my topic. At last, I would like to thanks and wish you a happy International Nurses Week. Thank you all.
Thank you, ma'am, for highlighting the real-world challenges faced during implementation of evidence-based nursing practice and providing practical solutions to overcome them. Thank you so much, ma'am. So before moving on for the next session, I would like to invite Ms. Jyoti Bala, ma'am, Assistant Nursing Superintendent, SGPGI MS, Ms. Rita Kumari, ma'am, Assistant Nursing Superintendent, SGPGI MS, and Ms. Shabana Khatun, ma'am, Associate Professor, College of Nursing at SGPGI, to kindly come on the dais for moderating the next session. It is now my pleasure to invite Ms. Nivedita De, MSc Nursing in Obstetrics and Gynecology, and a PhD scholar under the INC Consortium, who is presently serving as a nursing officer at ESI Hospital at Kolkata. Today, ma'am will deliver her expert opinions on evidence-based infection prevention in OBG wards and labor rooms. Ma'am, the platform is yours.
Am I audible? Hello, am I audible?
Yes, ma'am, you're audible, ma'am. And your slides are visible too, ma'am, but can you please make it go full screen, ma'am?
Now is it visible? Full screen?
Yes, it's good enough, ma'am. Thank you.
Okay. So a very good noon to everyone. I am Ms. Nivedita De. Currently, I am working as a nursing officer in ESIC Joka, Kolkata. I am MSc Nursing, completed my MSc Nursing in OBG obstetric nursing. So my topic is evidence-based infection prevention in OBG wards and labor room. The outline of my presentation is introduction, contributing factors of maternal sepsis, active prevention and treatment of maternal sepsis, aseptic delivery practices, COTI prevention, post-cesarean wound care, maternal sepsis prevention under national programs, conclusion and references. Embrace your role as a nurse with the knowledge that your care changes lives. So introduction. We know that maternal mortality ratio is 197 in 2023 worldwide and around 88 in India. To achieve the SDG target of under 70 by the year 2003 or 2030 requires a nearly 15% annual reduction rate. Pregnancy-related infection and sepsis causes 10.7% of all maternal deaths worldwide, whereas 12% in India. Now, according to WHO, proper infection prevention practices can prevent nearly half of avoidable maternal infections. Now, what are the contributing factors of maternal sepsis? We know that so many factors are contributing to maternal sepsis. Broadly, we can divide those factors into 3 points: institutional factors, maternal factors, and miscellaneous factors. So, institution plays a very important role in formation of maternal sepsis also and continuation of maternal sepsis also. So, what are those factors? First of all, inadequate infection prevention practices. We know that in every hospital there should be one infection control nurse, but in many of the settings we can observe that there is no any infection control nurses. Besides that, there are no any infection control protocols also. Very below compliance, very less compliance of hand hygienic practices also. Previous speakers also very put importance in the factors of hand hygiene, hand washing, but we can see that there are very less compliance of hand hygiene in so many settings. So these all contribute to the maternal sepsis. Second is healthcare system and workforce limitations. A country like India, we know that there is a very shortage of skilled birth attendants, nurses, and obstetricians. So these affects our maternal sepsis, our census of maternal sepsis also. Unsafe clinical and obstetric practices, repeated vaginal examinations, unnecessary vaginal examinations. They cause chorioamnitis and also other infections. So there are another institutional factor, that is inappropriate antibiotic use. We know that very misjudged and unnecessary excessive use of antibiotic, this can cause antimicrobial resistance. So these also causes increasing of infections in mothers and child and neonates also. So the maternal factors. Maternal factors is poor maternal health and nutritional status. We know that around 52.2% mothers of India are anemic. So anemia already predisposes a mother to the causation of infection because her immunity status is very, very poor that time. Nutritional status also, malnutrition. This can cause the formation of infection and delayed healing of post-cesarean section wounds. And also immunocompromised situations like HIV. This also predisposes a mother to infection. Second is obstetric and reproductive complications. Complications like prolonged rupture of membrane, prolonged labor, all those things, they causes delayed healing of episiotomy wound, and also in the causes of chorioamnitis and other infections. Poor maternal hygiene. We know that there are so many mothers, they don't know about proper perineal care and how to maintain the hygiene after the in the postpartum period. So this can causes infection. Delayed utilization of healthcare services. For poverty, for lack of transport and other barriers, we know that utilization of healthcare services that is already available in our country, but the mothers cannot have it, cannot have these services because of delayed utilizations. They also, poor referral system is responsible for this. Now the other factors, socioeconomic and educational barriers. Here comes poverty. We know that people due to poverty, they can't access proper obstetric care. And educational barrier, illiteracy and low literacy, they don't know about proper care to the episiotomy wound or the cesarean wound. They don't know the wound care. Second is unsafe cultural and traditional practices. Some areas they also perform home deliveries. These causes because of their culture and traditions, and some cultures they restrain the intake of certain fruits, certain foods, and also they restrict the intake of water also in certain cultures. So these all contributes to the formation of sepsis and formation of infections. Limited healthcare access and system challenges. There are so many system challenges. My previous speaker she discussed about this, the system challenges like poor transport, poverty, and all those delayed referral systems. These contribute to the formation of infection. So these all other factors for which the maternal infection causes. Emerging public health threats like COVID-19, we know that during this pandemic, the mothers, they cannot access proper obstetric care, and also antimicrobial resistance due to the excessive use of antibiotics and non-judgmental use of antibiotics and self-medications also. There is the antibacterial microbiome, the resistant bacteria like MRSA and ESBL, they also emerge. They also causes maternal sepsis. Sorry. Active prevention and treatment of maternal sepsis, APT sepsis. The WHO supported active prevention and treatment of maternal sepsis, that is APT sepsis program, conducted in hospitals in Malawi and Uganda, involving over 431,000 women. So what they did, they include strengthening of hand hygiene practices, routine monitoring, aseptic practices, and timely sepsis management. That these management, they only reported a 32% reduction in infection related maternal mortality and severe morbidity. Now we'll discuss about aseptic delivery practices. Aseptic delivery practices refer to evidence-based infection prevention measures during childbirth to prevent maternal and neonatal infections. According to World Health Organization, these practices are operationalized through the 6 cleans. We all know about the 6 cleans. So first is clean hand hygiene. WHO recommends that only hand hygiene can reduce 50% of all infections. So it is very important to maintain this hand hygiene properly. At least for 20 seconds, we know, and with hand wash or soap, and alcohol wrap. If alcohol wrap is available, then it is also we can use. So clean hands are very important. Second is clean mother. Clean mother means clean perineum. So before doing any vaginal examinations or normal delivery, so we need to clean the area with our protocols, by maintaining our protocols with antiseptic solutions. Third is clean delivery surface. That is a clean, dry delivery surface. Nowadays, that safe kit is available. That is a sterile kit, delivery kit is available that makes the delivery area clean and sterile. So that should be used. Second is clean cord cutting. So we know that to cut the cord, we always should use a properly sterilized instruments. No any unsterile things or wet things or other non-clean things should not be used. Then clean cord tying. After cutting also, the tie or the clip we are used, that should be sterilized, at least clean in case of home delivery. But ideally it should be sterilized. Clean cord care. So cord care is a very important part. After cutting the cord, the stump should be maintained in a dry condition. No other traditional practices like applying honey or any other ointment, powders and etc. should not be applied. So it is very important to provide the cord care. If we are providing the cord care, then it should be sterilized. If we are not providing that, we should at least educate the mother or family members about the cord care. So these are the 6 cleans about safe birth. So next we'll discuss about COTI. Sorry. My previous speaker, Shaban ma'am, already discussed about COTI. So in obstetric patients, we'll discuss the COTI. Now, approximately 75% of hospital acquired UTIs are linked to urinary catheters. Incidence density of COTI among hospitalized obstetric and gynecology patients was reported as 1.28 per 1000 catheter days in a large tertiary hospital study. The risk of bacteriuria increases by 3% to 7% per day of catheterization. Obstetric patients undergoing cesarean section and prolonged labor are at higher risk. Nurse-led catheter removal protocols can reduce COTI incidence by up to 50%. Why nurse-led catheter removal protocols? Because we know that nursing persons are the person, they always accompany the patients. They know that they can maintain the time limit, that for how many days it is maintained, how many days it is remained. So it is very important to have this nurse-led catheter removal protocol. Now it is a COTI bundle. We know that in every institutions we are maintaining this COTI bundle nowadays. There are several points. First of all, we have to mention the patient details. Then certain points are there like hand hygiene, yes or no, catheter necessity, yes or no, catheter properly secured, yes or no, daily metal cleansing, yes or no, sterile closed drainage system, yes or no, collecting bag below bladder level, collection bag below bladder level, yes or no, and collecting bag less than 75% full, yes or no, and no kinks or obstruction, yes or no. So we'll see this in detail. Now, avoid unnecessary urinary catheterization. So in obstetric patients, we know that routine catheterization is absolutely not recommended. We can only catheterize in necessary patients, like in a cesarean section just for that day, and in other patients like in complications, eclampsia, preeclampsia, these types of patients only need catheterization. So there is a particular indications for catheterization. If that indication is present, then only we can catheterize the patient. Not routine catheterization is advisable. Second is maintain strict aseptic technique during catheter insertion. If catheterization is advisable, then we have to maintain strict aseptic technique with sterile gloves, with PPE and other. The area should be sterilized, and also the metal cleaning is necessary before catheterization. Ensure closed urinary drainage system. That is, we are also maintaining. Keep urine drainage bag below bladder level. Avoid unnecessary disconnection of catheter and tubing. Daily assessment for early removal, early catheter removal. So in cesarean patient, we know that early ambulation, it is recommended for the early removal of catheter only, and plenty of fluid intake. We will encourage the patient to intake fluid. That the intake of fluid, they can induce urine, and then we can remove the catheter. Use nurse-led catheter reminder or stop order protocol. So we are calculating how many days this patient is having catheter. In case of fistula or any other bladder injury, 7 or 10 days catheter is advisable. So seeing this, we will inform the physician to remove the catheter earlier. Provide perineal hygiene and catheter. You know that how much important it is to give proper perineal hygiene and catheter care if the patient is having catheter. because it will reduce COTI in a large amount. Monitor and document signs of urinary infection. So early monitoring and early recognition of infection is very important to heal the infection very fast. Implement COTI surveillance and infection control audits. Many of the hospitals, they don't have any data regarding the COTI numbers, and the audits is not happening in a periodic form. So it is very important to have the proper number, how many COTI infections are happening in how many COTI are happening in the obstetric wards. So the number only we can take, from the number only we can take the decisions that we need to have any evidence based practice, need to have any apply any new evidence based practice or not. Then antimicrobial stewardship practice. So routinely giving any antibiotic for catheterization is not advisable, but if any signs of infection is there, then we have to inform the physician, and according to this antibiotic should be prescribed. Now, post-cesarean surgical site infection. Globally, the incidence of post-cesarean surgical site infection is approximately 5.6%. In low and middle income countries, approximately 11% of surgical patients develop SSI, according to WHO. SSI rates after cesarean section ranging from 5 to 20% in India. We know that nowadays the number of cesarean section is increasing. That the non-judgmental use of cesarean section is always using. So after cesarean section, there is a increased chance of having surgical site infection. So we have to have a close vigilance on this. Now the post-cesarean wound care. Now the wound care strategy is pre-operative antibiotic prophylaxis. The supporting evidence is administration of prophylactic antibiotics within 60 minutes before skin incision significantly reduces surgical site infection rates after cesarean delivery, according to WHO and NICE. Second is chlorhexidine skin preparation. Alcohol-based chlorhexidine skin preparation is more effective than povidone iodine in reducing wound infection, according to WHO SSI guidelines. Now, evidence-based surgical site infection prevention bundles. A 2025 systematic review and meta-analysis, including 32,709 women, reported that care bundles reduced post-cesarean surgical site infection risk by 71%. Surgical site infection incidence declined from approximately 5% to nearly 0 to 1% after bundle implementation. Now, maintenance of sterile dressing for 24 to 48 hours. Postoperative wound dressing protect the incision from contamination during the critically early healing period, according to NICE. Now, daily wound assessment by nurses. So, it is a very crucial step. Daily wound should be assessed by the nurses, because nurses the only person, they can closely monitor the wound, that about the drainage, the soakage, the color of the soakage, all those things. So, it is very important to daily assess the wound and also document the wound assessment, because without documentation, we know that there is no value of this assessment. So, WHO SSI guidelines emphasize post-operative wound surveillance. Now, there are some another aspects: optimizing maternal nutrition and glycemic control. As I told previously, that glycemic control is very important, because glycemic control will determine the wound healing time. So, adequate protein intake and diabetes control improve collagen synthesis and wound healing while lowering infection risk. High risk mothers require enhanced post-operative monitoring. So for this post-operative monitoring, we know that in most of the hospitals, they have a checklist for post-operative monitoring. In that checklist, they have the wound dressing frequency, and also the type of the dressing, and also the condition of the dressing. This should be maintained, and for high-risk mothers, this should be maintained properly and very closely. Patient education on wound care and discharge. So we are the person, we are taking care at the hospitals, but at the home, what they are doing, we don't know. So we have to educate the patient properly about all these aspects of wounds. So WHO recommends patient engagement in SSI prevention, because without engaging patient and family members, it is impossible to control the maternal sepsis and other infections. Finally, negative pressure wound therapy. This will the next decades, this will change the condition of the postoperative dressing. This is a very revolutionary invention, you can say. That is negative pressure wound therapy and vacuum therapy. It may reduce SSI and wound adhesions in high risk women like obesity and diabetes. We know that in obese and diabetic patient, secondary and tertiary suturing is sometimes needed, very frequently needed due to infections. So NPWT and VAC, this can reduce this necessity of secondary and tertiary suturing, and also they will decrease the morbidity of the patients also. Studies demonstrate improved wound healing and fewer wound complications. So there is a picture of this negative pressure wound dressing. We can see that after applying the dressing, the negative pressure instrument is applied, which drains the exudate away from the wound, and it also helps in the thermoregulation and modulation of the healing. So this is another picture of this negative pressure wound therapy. Now, maternal sepsis prevention under national programs. So the government of India also taking initiatives for reducing this maternal sepsis. In every national, in so many national programs, these strategies are taken. First of all, Laksha program. We know that it improves labor room and maternity OT quality through infection prevention, aseptic delivery practices, and maternal safety protocols. Second is Janani Suraksha Yojana. It promotes institutional deliveries under skilled supervision to reduce maternal infection, sepsis, and preventable maternal deaths. In Janani Sishu Suraksha Karyakram, they provides free maternal and newborn healthcare services to ensure timely treatment of infections and obstetric complications. Now, infection management and environment plan (IMEP). It strengthens infection prevention and biomedical waste management practices, and also minimize healthcare associated infections. Other programs are Dakshata program. As we say that we are a resource poor country, we don't have proper skilled birth attendants and also obstetricians. So this Dakshata program, it enhances the quality of intrapartum and postpartum care through skilled birth attendants and adherence to aseptic delivery practices. Then national IPC guidelines, it standardize hand hygiene, sterilization, environmental cleaning, and antimicrobial stewardship practices across healthcare facilities. Then skilled birth attendant SBA program, it trains nurses and midwives in clean and safe delivery practices for early prevention and identification of maternal infections. Then maternal death surveillance and response MDSR. As I mentioned, that surveillance is very important to know that where we are standing. So it will inform us about how much we have to do right now. So for this MDSR, it identifies the causes of maternal deaths, including sepsis, to improve obstetric care quality and infection prevention strategies. Then Suman Surakshit Matrita Aswadan, we know that this ensures the institutional delivery healthcare services with emphasis on clean instruments in delivery and emergency obstetric care. So all these things, they control the infection rate and they also reducing the maternal morbidity and mortality also. So to conclude, India has implemented multiple evidence-based national programs to prevent maternal sepsis. The care bundles improve outcomes, as we know that so many care bundles like COTI care bundles and surgical site infection care bundles, this can improve outcomes. And the most important is nurses are the key leaders. We can change the system. So we have to take the action and with the proper knowledge. Now these are my references. Thank you. Any questions? Okay, so thank you. And once again, advanced happy Nurses Day to all.
Thank you, ma'am, for your highly informative session. For the next session, I would like to invite Ms. Anita Walter, ma'am, Deputy Nursing Superintendent at SGPGI Lucknow, and Ms. Rita Pandey, ma'am, Assistant Nursing Superintendent at SGPGI Lucknow, to join us on the dais. I also request Ms. Pratibha, ma'am, Assistant Nursing Superintendent at SGPGI Lucknow, to join us on the dais.
I'm happy to invite our next speaker, Ms. Meera Prajapati, who is also my acquaintance from LHMC College of Nursing. She is currently working as nursing officer in AIIMS, Delhi. with background in psychology and hospital administration. She will speak on prevention of surgical site infection, nursing role in OT.
Good morning, good afternoon to all. Am I audible?
Yes, you are audible, Meera.
Okay, thank you for the opportunity, and I feel honored to have this opportunity, and I hope this presentation will be informative and meaningful for everyone. Today, I'm here to present on the topic prevention of surgical site infection, nurses' role in OT. Just today our topic is prevention of surgical site infection, evidence-based preventions, and what are the nurses' role in OT. So we'll be discussing what is SSI, surgical site infection. We'll be discussing the burden it pays on the hospital. We'll be discussing what are the common causative organisms that causes the SSI. We'll be discussing the risk factors, prevention bundles, key nursing practices, and we'll be seeing the evidence-based nursing interventions and recent studies which has been done in this area. So what is SSI? SSI is an infection occurring within 30 days of the surgery in the body area where surgery took place. Why SSI prevention is important? Because it is the most common and costly healthcare association infection. It increases morbidity, pain, delayed healing, and readmissions. It also prolongs hospital stay by 7 to 10 additional days. It raises antimicrobial use and contribute to the resistant. It also causes significant financial burden for the hospital and patients. 41 to 70% of the SSI are preventable through the bundle of cares. So this is the statistical data that 15 to 20% of the hospital acquired infections are due to the SSI, and it also increases the mortality rate by 2 to 3% with the SSI, and it also pays the extra cost burden on the hospital like 8 to 20 lakhs INR for the SSI cases, and it also prolongs the patient stay in the hospital like 7 to 10 days extra with the infection. So what are the common causative organisms that leads to the SSI? We have the gram-positive bacteria, gram-negative bacteria, and anaerobes and fungi. First, gram-positive bacteria like Staphylococcus aureus, methicillin-resistant Staphylococcus aureus, or Streptococcus species. Now, gram-negative bacteria, it includes E. coli, Klebsiella, Pseudomonas, and anaerobic and fungi. It's like bacteriocide species, Candida species. We'll be discussing now the risk factors that cause the surgical site infection. So we have the patient factor. Okay, what are the patient factors which lead to the SSI? We have like if the patient has the diabetes, history of diabetes and perioperative hyperglycemia, if the patient has obesity, BMI more than 30 and smoking history, age more than 65 years, malnutrition and anemia, if the patient is immunosuppressive or it has the remote infections or any skin breaks. So these all patient factors lead to the SSI later on. We have the procedural factors, like if the operation time during the surgery is more than 2 hours, it can also lead to the more bacteria to accumulate. Next is the contaminated or dirty wounds. If any emergency procedures is happening, because in the emergency we don't have the much time to prepare or to make this sterile field, and so this can cause to the SSI. If the blood loss is more than 500 ml, if there is any tissue trauma or dead space, improper hair removal, or delayed antibiotic prophylaxis. Now we have the environmental factors. Environmental factors include excessive or traffic in the OT, intraoperative hypothermia, poor air quality or ventilation, instrument reprocessing failures, breaks in the sterile technique, poor hand hygiene compliance, or inadequate oxygenation. So these are the risk factors which causes the surgical site infection. Now we have the surgical SSI prevention bundles, evidence-based interventions across the perioperative journals. So we have the bundle which includes the 8 key roles, which 8 interventions which together binds or together forms the bundle. So 15 to 20% of all hospital-acquired infections are due to the SSI. Now let's look at the prevention bundle. This is the heart of our presentation. The wheel diagram of the left side shows 8 key interventions that form SSI bundle. Antibiotic prophylaxis, skin antisepsis, hair removal, normothermia, glucose control, hand hygiene, sterile technique, and wound care. The key concept is a bundle, means togetherness. No single intervention prevents SSI on its own. It's the consistent application of all these measures together that achieve to reduce the SSI later on. The image on the right side shows how this intervention maps across the 3 perioperative phases, which has been given by the WHO. So we'll be discussing each phase in the detail. Now, first phase of the prevention of SSI is pre-operative preventive measures. So in the pre-operative preventive measures, it means key prevention of the infection before the incision. So it includes patient assessment. Patient assessment, nurses should assess medical history, existing infection, allergies, any nutritional status or deficiency, blood glucose level. Then we have the patient bathing before the surgery. Ensure preoperative bath, shower with soap, antiseptic the night before or the morning of the surgery. Assess the skin integrity. Now for the hair removal, do not remove hair unless it interferes with the surgery. If necessary, use clippers immediately before the procedure. Never use razors because it can cause the micro trauma which can cause to the SSI later on. Now we have the antibiotic prophylaxis. Administer the antibiotic within the 60 minutes or 120 depend on the bacteria. Ensure bactericidal levels at the incision time. Now we have the skin antisepsis. Use alcohol-based skin preparation unless contraindicated. Allow to dry completely. Ensure site is free from the gross contamination. Then we have a patient optimization. Support smoking cessations like 30 days before the preoperative plan, dietary control, nutrition review, any anemia or treat remote infections. Checklist readiness. Verify consent, allergies, antibiotic timing, site marking, sterile supplies, or patient education completion. Control of the blood glucose. We must ensure the patient glucose level are up to the optimal level or recommended level. Hyperglycemia increases bactericidal growth and delay healing. And final and the most important thing is patient education. Teach patient about its personal hygiene, importance of nutrition, wound care, and signs of infection. Now the next phase is intraoperative prevention phase. Means during the surgery, how the evidence-based practice prevent the SSI. First and foremost important thing is hand hygiene. Surgical hand antisepsis. All surgical team members must perform surgical scrubs. Methods like antimicrobial soap scrub or alcohol-based hand scrub. Another is sterile technique. Maintain aseptic environment. Use the sterile gloves, sterile drapes, sterile instruments. Now we have the proper operating room ventilation, positive pressure airflow, HEPA filtration, control traffic in operating room. Then the next important aspect is the sterilization of instruments. For sterilizations, we use different methods like steam sterilization, ethylene oxide, plasma. So nurses must ensure proper sterilization indicators are checked. Now the maintenance of normothermia. Hypothermia reduces immunity in the patient. So how we can maintain the normal thermia? Like by giving the warm IV fluids or patient warming devices. Now we have the surgical technique. Surgeons should minimize tissue trauma, achieve homeostasis, remove dead tissue if there is any, or prevent contamination. Now the hand hygiene is very important. Like I have given a separate slide on this hand hygiene because it's the single most important measures in preventing healthcare associated infections including SSI. The WHO 5 movements framework on the left side shows how hand hygiene must be performed before patient contact, before any aseptic task, after body fluid exposure risk, after patient contact, or after touching the patient surrounding. The reference image on the right side specifically applies this movement to the post-operative care. Every time we approach a surgical wound, change a dressing, or handle a drain, hand hygiene is a non-negotiable. It's simple, it's evidence-based, and it saves many lives. Now we have the post-operative wound care and the surveillance, monitoring, educating, and early detection. In this, we focus on dressing and hand hygiene before and after the wound contact, aseptic technique for all the dressing changes, sterile drain care and output monitoring, change dressing when wet or soiled or loosened. Now we have the wound assessment. Monitor redness, vomit, swelling, pain. Assess discharge character, wound edges, order. Check for any drain output quantity or quality. Report early changes promptly to team. Then patient education. Teach incision care and signs of infection. Tell the patients to observe the sign of patients, bathing instructions and activity restrictions, medication adherence and nutrition guidance, when to seek urgent medical review. Then we have a discharge checklist. Written wound care instructions provided, follow-up date or instructions given, teach by confirmation, documented, surveillance or continuity of care ensured. Then we have an early detection of the infection. Monitor for any signs of fever, pain, swelling, drain. Prompt reporting prevents complications. Now we have the nutritional support. Encourage patients for the high protein diet, vitamin C diet, zinc or adequate hydration. Look for the glycemic control. Post-operative blood sugar monitoring is very important. Drain management, because sometimes, many a time the infection, the most common way to enter the infection is the drain. So maintain the patency and sterility of the drains. Now we have the nurse's central role in the SSI prevention, care responsibility across the perioperative continuum. Now before the surgery, what we are supposed to do, screen for infection risk or optimize modifiable factors, confirm pre-op bathing, fasting, allergies, antibiotic timings, educate on skincare, smoking cessation, glucose control, verify checklist completion, and patient readiness. During the surgery, protect sterile field and correct breaks immediately. Monitor temperatures, counts, specimens, positioning. Coordinate with surgical and anesthesia team. Document bundle compliance and any contamination event. After the surgery, we are supposed to perform a wound assessment, dressing care, drain management. Then provide a clear discharge teaching with teach back. Accelerate the early signs of sepsis and wound deterioration. Ensure follow-up appointments and surveillance documentation. Now we have the quality improvement. Participate in surveillance audits or checklist adherence. Promote continuing education and protocol update. Model evidence-based practice for junior staffs. Contribute to feedback cycles and process improvements. Now we have the evidence-based interventions. Like strict hand. If I want to conclude my whole slide, it's like the foremost important thing is strict hand hygiene. Most effective infection prevention measure. Use of PPE, gloves, gowns, masks. Then the aseptic dressing techniques, which prevents contamination. Fourth is environmental cleaning. Maintain clean patient environment. And the last one is surveillance and monitoring. Track infection rates and report the trends. The recent studies which has been done in the previous, and which shows the how the nurses have applied the bundle of care or the WHO guidelines in order to prevent the SSI effectively. First study is operating room nursing intervention in orthopedic surgery 2023. What they have found out that SSI incidence reduced from 13.24% to 2.85%, which is quite a significant reduction. Strong evidence is that nurses' intervention reduce wound infections. Another study has been done, multifacet SSI prevention bundle study 2023. They have found out that multifacet bundle reduce SSI risk significantly. Bundle approach is more effective than any single intervention. Third study has been done, nurses-led close incision negative pressure therapy study 2025. Their findings are nurses manage close incision negative pressure therapy, reduce superficial and deep SSI, improve wound healing and patient comfort. Another study is systematic review of nursing interventions for infection prevention 2026. Their findings are multimodal nursing interventions significantly reduce hospital-acquired infections. Integrated approaches are more effective. And the last point is qualitative study on nurses SSI prevention practices 2026. Their findings are proper aseptic techniques or dressings and patient education improve wound healing. So, what are the takeaways? SSI is the most common hospital-acquired infections. Among 15 to 20% of the nosocomial infections, increased costing per case with 7 to 10 days extra of hospitalization. Prevention bundle actually works. Standardized evidence-based bundles reduce SSI by 41 to 71% when consistently applied across all phases. Nurses are central to prevention, from risk screening to discharge education. Nurses coordinate and execute every element of the prevention bundle. Quality improvement is essential. Continuous audit, surveillance, feedback, and education drive sustained SSI rates reduction. Every step matters. No single intervention prevents SSI alone. The bundle approach ensures comprehensive protections. These are my references. Thank you for your attention. I would like to close this thought. Through vigilant prevention bundles, evidence-based practice, and our unwavering commitment to patient safety, we as a nurse prevent surgical site infections and save lives. If anyone has any question, feel free to ask. I would like to express my sincere gratitude towards giving me this opportunity, and this has helped me to learn and grow academically. And I'm happy to share this presentation with you all. Thank you for listening me so patiently. Thank you.
Thank you, Ms. Meera, for your excellent presentation. Your session beautifully emphasized the central role of nurses in ensuring patient safety in the operation theater settings. So before moving on for the next scientific session, I would request Ms. Ansi Jairaj, ma'am, Deputy Nursing Superintendent, Ms. Aditya Kumari, ma'am, Assistant Nursing Superintendent, and Mr. Sunil Maurya, sir, Assistant Nursing Superintendent, to kindly join us on the dais for moderating the next session. It is now my honor to invite Ms. Sharon Shiba Thambitrai, ma'am, who is a gold medalist in MSc Critical Care in Nursing and presently working as a nurse practitioner in the UAE. Ma'am possesses a rich clinical experience in adult critical care ICUs, neonatal ICUs, in the departments of midwifery, infection control, quality, and patient safety. Ma'am is also a recipient of the Gold Nurse Researcher Award and Florence Nightingale Award for Best Outgoing Student from Dr. MGR University at Tamil Nadu. Ma'am has also been bestowed with the Quality Crown for Patient Safety by Sri Ramachandra Hospital. Ma'am will be speaking on the topic of importance of evidence-based nursing in critical care nursing. Over to you, ma'am.
Okay. Good afternoon, all. Am I audible?
Yes, ma'am, you're audible, ma'am.
Okay. Okay. It's my pleasure and privilege to present today's topic, the importance of evidence-based practice in nursing. So our goal is to understand how we can integrate clinical science to achieve the absolute best outcomes for our patients. I think I have shared my PPT. Is it to the organizing committee? Has it been displayed?
We'll display it for you, ma'am.
Okay. Sorry, not this one, the other one. Importance of EBP, not this one. The fourth, yeah.
If the slides are visible, you can go ahead, ma'am.
Yes, thank you. As I said, the presentation is about importance of evidence-based practice in nursing, integrating clinical science for optimal patient outcomes. It is to understand, to go from our traditions to evidence-based scientific reasons to follow our clinical practice. Next. So what is evidence-based practice? As we're listening to the presenters before, they have already emphasized what is it. So again, coming to that, it is the best current research evidences that is available now. It's not about the old thing. It is a newer thing that we are updating towards the future. So clinical expertise and experience, patient values and preferences. So it is to empower our nurses to move beyond tradition-based care to scientific-based evidences for the nursing care excellence. So defining what is the standard of care. So evidence-based practice is a conscientious, explicit and judicious use of current-based evidences to make best decisions about care for individual patients. So as I said, it is the factors are like focusing on outcome, quality pillars and safety net. So improving our recovery rates and clinical metrics are important when we focus on outcomes. And quality pillar is like standardizing interventions across facilities available in various global levels. And safety net, reducing preventable harms and errors so that we will reduce the admission length of stay in ICUs or in the hospital and preventing readmissions. So what's the three pillar of the evidence-based practice, like best research evidences and clinical expertise and patient preferences. So best research evidences is like the up-to-date randomized control trials we are doing to validate the findings that are best for the patient care. And clinical expertise in the sense, it's not like theoretically we are proving something and keeping it in the books. It is like the nurse's professional skill and judgment to make progress in day-to-day life. And patient preferences, it is really important because what the patient prefers and what the cultural beliefs are there and what is their personal goals for their health journey is important. So why? This is my core of my presentation. So we say evidence-based practice is important. And you may ask why? Why evidence-based based practice should be used? So there are various factors that influence or emphasize or insist the evidence-based practices importance. So it increases patient safety. It reduces the risk for adverse events that may occur in their length of stay in ICUs. So I'm focusing on critical care that is we are giving in ICUs. So optimizing the outcomes. So scientifically proven recovery paths are based on the outcomes that we provide to the patients, and supporting decisions. And this decisions should be from the evidence, not from the guesswork we are doing. Of course, we do researchers, lot of trial and errors, and we come out with the best experiences or best evidences that can be given as support decisions for our complex cases. So reducing cost, it is our accountability that every penny that the patient spent is we are responsible for that. So shorter stays and fewer readmissions are our goal ultimately, and providing optimal health to the patient. And patient satisfaction, when we carry out all these factors, patient will be satisfied with their health, and they will be moving to the path that they could take care of them with the alignments or the health education we give to them. So the reduction in care variation was 82% when we provide evidence-based protocols and strictly following it in our acute care settings. So this evidence-based practice is not framed by us. It is not a today's process. It has come from our pioneer. Florence Nightingale in her 1850s has started this with the basic evidences, with the sanitation, with hand hygiene, ventilation. She reduced the mortality from 42% to 2%, which was later strengthened by Dr. Aki, formalizing the hierarchy of evidence, what is now we are following as a global evidence-based practice movement. So how can we evaluate this? It is a step, it is a process. So you have to ask, formulate a clinical question. You have to acquire the knowledge of evidences. You have to appraise the clinical evaluation, validity, and utility, and apply what you have gained from the insights you have gained. And you have to again reassess if it's working, if the evidence-based practice is appropriately being given to my patient. So this is about my study, which I did in my post-graduation, the PICOT elements. Based on that, what is the patient you are caring? What is the intervention you have given? What is the comparison that is standard to the alternative thing you have tried, and the outcome and time taken for your achievement. So I have taken the ventilated ICU patient, and the intervention I gave was volume-based feeding, and the standard care that was used in the hospitals was rate-based feeding. It is based on the nutritional status improvement for the patient given, and I measured for about 7 days of initiation of my study. So with this appropriate protein provided to the patient, I was able to observe the best outcome in their weaning probability from the ventilators. So this method we have to assess, imply, and note the outcome of the patient if it's been applied appropriately. That's helping them to get better health, and they are being discharged soon. So high quality evidences, we have sources from various things these days, not only books. We have many researchers have been done. We have databases, meta-analysis, global guidelines we have, and several nursing journals are emphasizing these evidences. Next. So impact on patient safety, there are there are possibilities of hospital acquired infections where in our healthcare. So if we practice evidence-based practices, before following the evidence-based practices, the hospital-acquired infections may be high. After following the appropriate care bundles in ICUs, the evidence-based practice standards, the hospital-acquired infections variations are becoming low. So it's important. We have a success story that we have been following hand hygiene. We are adhering to the hand hygiene. We are using all antiseptic solutions that is being resulting in 50% of decrease in CLABSI in ICU settings. Next. Okay. Evidence-based in critical care, we have a lot of infection control bundles. It is vital in critical care settings that we mobilize the patient early and prevent the skin impairment. So it's been emphasized that with all these evidences, WAP bundle, we are elevating the head, we are providing appropriate suctioning, we are using HME filters, and we are early mobilizing the patient to reduce the muscle atrophy, and skin integrity has been maintained. All these are from the evidence-based practices we are employing in our critical care settings. So now I have an insight on AI-driven predictive models from which we can prevent the sepsis in a golden hour. In 1 hour time, if the lack of resources, we will not be able to find the cases or find the diagnosis of the patient. So early identification through AI-driven predictive models are reducing the sepsis rate by over 15%, and initial lactate measurements, immediate blood cultures, and starting before antibiotics and rapid fluid resuscitation will definitely emphasize the reduction in sepsis within the golden hour time. So another important I insisted before is cost. Through the evidence-based practice, the cost per infection case is high, and if we follow the evidence-based practices, the cost of preventing the infections and the cost that is being spent by the patient, reducing the length of stay and readmissions can be reduced. So what's in hands of nursing professional? To empower, it is important for the nursing professionals to empower through our knowledge, through enhancing our clinical judgment, to build our professional confidence, to promote critical thinking skills and encourage lifelong clinical learning. So it shows that improved trust, patient feel involved in the care, they get understand what is being done, what is being consciously they are watching what is the care we are providing. So if it's based on the evidences, we will be able to educate them on the care we are giving and high adherence to the treatment plans, so that patient will provide better outcomes consciously and satisfied with our care due to this enhanced nurse-patient communication. So, danger of tradition. I insisted this before. It is not the traditional practices we did in our practice, that is in the healthcare practice. It is about the evidences that we proved up to date. From tradition to science, we are moving. So the legacy practices are outdated. We are not checking the routine gastric residuals. We are not this all outdated things. So we should not have scheduled IV changes and aspirating IM injections. These are outdated. So the risk, we have to understand that non-evidence-based cares will lead to care variation, increased patient discomfort, and significant waste of clinical resources. So we had a global crisis, and the evidence-based practice showed that rapid adaptation of evidences, infection control, and proning protocols safeguarded our global health emergencies. So there are challenges in implementing, especially the top barrier is time. So 70% of nurses will are in lack of time, and resources gaps and resistance that we have in the cultural beliefs the patient have and knowledge difficulties. So in time here in UAE, I observed every patient has no time to wait for anything. So they'll go, they'll just enter. Here is no paperwork and all. So it is everything being electronically recorded in the machines, so that there are time constraints being saved here. So I notice a variation from Indian culture to UAE culture, global platform here. Next. So the bridges to better practice is that we have to educate, we should have a mentorship, we should be the lead for the evidence-based practice. So simulation and bite-size mini training modules, or pairing novice nurses with clinical experts, and protected time for research councils should be there for every nurses. So as a takeaway home, we nurses are the change agents. We have a role to support this evidence-based practice. Next. So as I said before, the digital future is going to come, not like we are going to have work from home like other professionals. It's like AI prediction that helps us in predicting our sepsis before 6 hours earlier, and the point of care guidelines we are having, and personalization on precision of nursing care based on the genetics complaints the patient have. So summary is like these are the key takeaways. The foundation, evidence-based practice is gold standard for clinical decision making. So we should be knowledged by this clinical practice, and aiming like it is important in the case of patients, like improving safety outcomes and cost simultaneously. So all these three are in our hands, and we are accountable for everything. And holistic care, it integrates science with human values and expertises. And it is essential that we grow professionally, and authority of nursing is not from today. It has been started centuries back, that we have a rich history and evidences to authorize, empower our nurses and nursing care. So to conclude, without evidence, healthcare becomes uncertain. So with evidence, nursing becomes safer, stronger, and more effective. So it is in our hands. We practice our evidence-based practices and give evidence-based best healthcare practices to our patients, not in an uncertain way or in a tradition way that we follow is by guessing or trial and error, but by with evidences that we have to deliver a best care to the patients. Thank you. Thank you. I thank the organizing committee for giving me this opportunity to present. Thank you.
Thank you so much, ma'am, for this beautiful and insightful presentation. So moving on for the last session of the day, joining us on the dais will be our moderators. I would like to invite Ms. Nurani ma'am, Deputy Nursing Superintendent, and Ms. Kalavati ma'am, Assistant Nursing Superintendent at SGPGI MS Lucknow, to kindly join us on the dais for moderators for the next session. For the final session, we have our distinguished speaker, Dr. Usha Malik ma'am, who is serving as an associate professor at Alia University in West Bengal. Ma'am holds a PhD and MSc in child and nursing and MBA in healthcare management. Ma'am has more than 25 years of teaching and clinical experience and has contributed extensively to research publications, including book chapters, attending and serving as resource persons in conferences and nursing leadership activities. Ma'am has received several awards, including Best Scientific Paper Award, Women Pride Award, and Best Teacher Award. Today, ma'am will be taking up the session on importance of evidence-based practice in neonatal nursing. Ma'am, we are honored to have you with us.
Very good afternoon. Am I audible?
Yes, ma'am, you're audible to us, ma'am.
Okay, very good afternoon to all of you. At the onset, I take this opportunity to extend my deepest gratitude to Sanjay Gandhi Memorial Postgraduate Institute of Medical Science and Madam Jin, who has given me this opportunity to stand before you in this platform. I will talk to you about today with the neonatal intensive care unit and also a few evidence-based practices of neonatal intensive care unit. So, can I share my slide, or someone will slide? Share.
If you have the slides, you can share yourself, ma'am, or should we share it from here?
Yes, I can, but I cannot see the sharing actually over here. Okay, let me try once.
Okay, ma'am.
Is it visible?
No, ma'am, not yet.
Okay, let me try again. Is it visible?
Yes, ma'am, it's visible now, ma'am. You can switch to full
Okay.
screen mode.
Yes, yes, I'm doing. Okay, can I proceed?
Yes, ma'am, it's visible. Thank you, ma'am.
Yeah. Once again, good afternoon. Before I going into the details about the NICU, let me tell you few things that why we actually send the baby to NICU. We are all expecting a normal newborn baby. So the few days before we have the 11th April 2026, it's a Safe Motherhood Day. Why I'm talking about Safe Motherhood Day? Because if we are taking care of the mothers from the antenatal period to internatal and postnatal, then there will be very less chances of the newborn baby who need to go to in neonatal intensive care unit. So Safe Motherhood actually giving the improved quality and increasing access to family planning and maternal health care services, and also educate the people for a safe pregnancy followed by a safe vaginal delivery. We are now emphasizing on the safe institutional delivery, implementing the evidence-based maternal newborn care practices over there, where we took care about the first stage, second stage, third stage, and after the delivery, where everywhere mother needs an intense and comprehensive care so that she can deliver a normal newborn, and the normal newborn cannot have any untoward symptom that she needs to or he needs to go to NICU. So if I'm talking about after all this in antenatal, intranatal and postnatal care unit, we have a very safe vaginal delivery or cesarean section baby. We talk about that the baby from birth to 28 days of the age is called newborn, that we all know. A healthy newborn is in term, that is the 38 to 42 weeks, the very important, should have an average birth weight for the country actually exceed 2.5 gram, it's minimum 2.5 gram, cries immediately after birth, following birth, and established satisfactory pulmonary respiration or independent respiration in this changing environment. Because baby is in intrauterine positions, now she came out to the world, so there will be fetal changes of the fetal circulation to independent pulmonary circulation. This is very vital. And after this, when we'll be taking care of the baby, definitely warm environment, appropriate bedding, clothing, and we will not put the baby in a wet temperature, wet clothes, and temperature should be maintained. And mother and baby should be in together, that called skin to skin contact, and baby will be immediately put to the mother's breast so that immediately able to suck the breastfeeding. And this is the very tips for the newborn care at a glance, taking immediate care at birth, such as delayed cord clamping. Nowadays, all of you know, it's evidence-based. There is a clear delayed cord clamping, immediate and competing drying, and skin to skin, maintain normal body temperature, encouraging breast milk, providing nurture and care, preventing infection, assessing health issues, recognitions, and responding danger signs. So we were okay till that term came as a danger sign. Baby will be delivered, baby will be either it is by cesarean or normal delivery, although we are nowadays, we are accustomed for the normal vaginal delivery. And after the normal vaginal delivery, baby will be establishing satisfactory pulmonary respiration, baby will be dried, baby will be having the delayed cord clamping, baby will be put to the mother's breast, and further the followed by care, the cord care, clamping, everything will be there. This much it was okay. But the complications arise when the baby is not in a position to normal. What happens when the baby needs to go to an ICU? Respiratory distress, that means baby did not achieve the pulmonary satisfactory respirations after birth. Baby very low birth weight. I told the 2.5 kg is the normal birth weight, and it may be 3.5, but lesser than 2.5 is always dangerous. And if you see nowadays, many babies are delivered and born with a 1.5, 1.2, 1.8 kg. In my NICU, we have given care of 700, 650 gram babies also. So severe to moderate birth asphyxia, baby may develop neonatal sepsis, maybe we are having meconium aspiration syndrome, jaundice, and congenital malformation. These are the very alarming for the baby, and because of that, these all types of the baby need to go to NICU, which we are not expecting at all. As you come to know that India's health scenario is very unfortunate to have still the maternal and neonatal mortality in a very severe high form. So talking about whenever baby is going to home also, suppose we are feeling that baby has delivered nicely and all the care and taken and baby has discharged with the mother. But in the home, it may happen that baby is not taking feed, baby is having too cold or too hot, baby's chest indrawing is there, is developing neonatal pneumonia, baby is having convulsion, no movement or palm or yellow skin, that means baby is developing jaundice or feeding intolerance. In that cases also baby need to come for the NICU. So in that cases, we can have the management of the respiratory support if baby is coming with the asphyxia. In the baby is having the maybe required blood transfusion, baby required skin to skin contact, neonatal palliative care, and also management of enteral feeding, infection prevention. Many things may be required for that. So that's the reasons we are very much aware, should be aware about the neonatal hypothermia. That is one of the most important causes for the neonatal mortality, and that can causes metabolic acidosis, pulmonary vasoconstriction, anaerobic metabolisms, reduce O2 supply, reduce O2 uptake, followed by there will be a hypoxia for the baby and baby can be died. And that's one of the reasons for the neonatal mortality. We are very still in India, we can go through many studies are going, only 67 to 72% having the exclusive breastfeeding, where we all know that 6-month exclusive breastfeeding is very crucial for the baby because it is required and it is very healthy practice. This breastfeeding can actually have the immunity transferred to the baby. But unfortunately, in a country like India, we are still not having more than 72% of the breastfeeding practices. Talking about my today's topic, whenever the baby, with this so many cares and utmost compassion, still if baby is going to an ICU, there are some evidence-based practice. As you know about me, myself, Dr. Usha Mallik, I have completed my MSc in Botany, MBA in Healthcare Management, MSc in Child Health, and followed by PhD in Nursing. Neonatal intensive care unit is a specialized hospital unit providing intensive medical care for the newborn who are born prematurely, that I told, have low birth weight, congenital abnormalities. There are many congenital abnormalities, that is that you see that PDA, patent ductus arteriosus, VSD, ASD, baby may having the tracheoesophageal fistula. So that all needs the baby to be transferred to NICU. And staffed by specialized healthcare professionals, including neonatologists, neonatal nurses, respiratory therapists, all are required to give care to the newborn babies who are in NICU. Now, evidence-based practice, if I NICU talked about it, is integrated the best available research evidence with clinical expertise and pattern values to improve care delivery and outcome. These projects help standardize care practice. Whenever we will be doing the evidence-based practice for the newborn, actually we have a tendency to decrease adverse event, and we have a goal to reduce the neonatal mortality, and show that the NICU team should be very skilled and efficient. So why we really need the ABP project for the newborn? Improve patient's outcome and reduce mortality and morbidity, standardizations of the care practice to reduce unwanted variation, enhance family involvement and satisfaction with care, and reductions in healthcare costs through prevention of complication. And as I talked about that key NICU ABP project that consists of the kangaroo care implementations, we have many studies that with the kangaroo care implementations, baby having reduced the hypothermia chances. Noise reductions is environment where baby is not feeling disturbed, especially when baby is in ventilator. Non-pharmacologic pain management is one of the most important area of the evidence-based practice for the newborn. Necrotizing enterocolitis is one of the most important and challenging issues for the health issues of the newborn. So we must be take care of the infections control. Family integrated care, we cannot provide the care to the newborn alone in the medical team, that need the mother or father or any family members interventions. Neonatal palliative care is most important. Apart from that, we know infections control and the standard protocols and developing supporting care, growth optimization. Suppose a newborn baby came with the 1.2 gram or 1.2 kgs, or baby came with the 700 grams. So growth optimization is very much required for that. Talking about the evidence-based practices in ICU, the neonatal intensive care unit utilizes the high-quality research, a clinical expertise, and family preference to improve outcomes for fragile newborns that I talked about. Key practices including developmental care, minimal handling, where it is actually required, we will be handling the baby according to. We need to reduce the noise and light, skin-to-skin contact, early breastfeeding, and standardized bundles to reduce infection. Although babies and immature, premature babies, low birth weight show susceptible to infection, so we must be very cautious about the infection prevention. So evidence-based practice which will be helping the newborn's outcome, that is the cost effectiveness, and the neonatal mortality will be reduced, and there will be good health indicators, and we can go for a good citizenship in India furtherwise. So talking about the best practices in neonatal care as evidence-based practice, we must be taking care of the golden hour, which is very important, focuses on stabilizing the newborn within the first hour of the post-delivery, reducing incidence of the intraventricular hemorrhage, hypoglycemia, and respiratory distress. If the first hour is very crucial for the newborn because she is transitioning, having point from the fetal to pulmonary circulation. So in this area, it is very crucial, and first 1 hour of that after delivery is called as a golden hour. As I talked about the developmental care, implementing minimal handling protocols to reduce stress and pain, we will be putting the baby in such a way that where minimum handling is required. Yes, definitely the being nurses will be taking care of the baby, but where it is not need to handle, continuous disturbance is not required for the baby, and that's called the developmental care. If the research shows if it is continuously handling the baby, there will be a delayed development in the weight and also other. Family-centered care, as I talked about, encourage patient and parent participation in care such as skin-to-skin contact, which improves the stability and promotes bonding. In our tertiary level in ICU, we are actually putting the mother in skin-to-skin contact, even the baby is in ventilator, and also putting the baby in breastfeeding through nasogastric wherever it is possible. If baby is out from the ventilator, although we are trying to make her only exclusive breastfeeding, without this we are not doing anything. So it's a very important issue for the pain management using non-pharmacological interventions like oral glucose, breastfeeding, oral sucrose, and positioning during painful procedure, as premature nervous systems are highly sensitive. Infection control bundles, standardized protocol for hand hygiene and line management, which are critical for preventing nosocomial infection. And finally, as I talked about, early use of nasal continuous positive pressure airway, because we are very much cautious about respiratory management. If it is not possible, then intubation is required. But intubation is required in a very gentle and skilled hand so that we can minimize the lung injury. Evidence-based practice in an ICU also require the noise and light, reducing ambient light and sound support to sleep and reduce distress. As I talked about, too much disturbing baby will be a delayed healing or delayed will be critical for the baby. So single family rooms or quiet shielded spaces are preferred to facilitate family-centered care and reduce infection rate. Essential stages that I talked about: golden hour, the preparations before birth, care at delivery, managing transport care in the neonatal unit. This is very much essential. Actually, in our practice, what we actually do, labor room, OT, and NICU are remain one after one, so that there will be no single times there will be loss of single time. We will be preparing the labor room or OT according to the temperature and based of the possibility of the baby. We will be having a warmer. Care at delivery, we will be having a very gentle delivery nowadays. And that is definitely a normal physiology of the birth. Now birth became a normal physiology. She will be insisting on the normal vaginal delivery. If we feel that baby is developing, if baby is creating any disturbance, baby has developed any birth asphyxia, immediate transport and care in the neonatal intensive care unit. This is a very golden hour, as I talked about. First 1 hour is very important. Better to say first half an hour. Golden hour care sits immediately nutritional emergency. So we must be talking about the infection prevention, kangaroo mother care, thermoregulations. As I talked about, hypothermia is one of the leading cause of death. Breathing is very important. Circulations and documentations and communication is very important. Talking about the developmental care, protecting sleep, as I talked about, reduce sound and noise, caregiving practices, environmental controls. Here, mother is being taught for the every care of the newborn. Even the baby is in neonatal intensive care unit, is the mother give the preference to care for the baby. Pain and stress management, kangaroo mother care, sucking, developmental activities of the living, feeding, diapering, and bathing. Family-centered care unit policies promote family access collaboration. Healing environment, sound, unit design, sensory motor experience, and positioning is required. We must be very careful about the positioning of the newborn so that she can or he can feel comfort. Healing environment, partnering with families, positioning and handling. safeguarding sleep, minimizing stress and pain, protecting skin, optimizing nutrition. If we think about the newborn, they does not have any stress or pain. It is absolutely wrong idea. Neonatal nurses who are very much acute with the newborn baby, they understood the stress and pain of the newborn. Although they cannot able to express, but by their crying, they can, even though in ventilator, they can able to express by their hemodynamic stability that they are in stress and pain. As I talked about family-centered care in NICU, it supports the parent-infant attachment, parental presence, and active participation in the daily care and decision-making is one of the most evidence-based practice in today's NICU. Talking about the father, partner, significant other, baby, mother, dad, or baby or mother, baby as interactor, family as a support is very important. At the same time, environmental protection, individual care, and infant mental health is very important. Components of the comprehensive family support, family-centered developmental care, mental health professional, peer-to-peer family support, palliative environment, post-discharge follow-up. Whenever the baby is getting discharged from the NICU, the follow-up care should be very good, and the staff educations and support to the mother and family. Talking about the pain management, many studies are going on. Myself also done a study on the pain management of the newborn, where we have done the dim lights, reduced noise repositions, having actually helping the baby to be recover early. Felicitated tuckling, as you know, nowadays we are doing the saddling. We are putting a bed-like, nest-like structure, and from there we are putting the baby over there so that baby feel that yes, I am not in a vacant area, I am in a very safe guard. So we are under the warmer or under the NICU bed, we are putting a saddling-like structures and we are putting the baby over there. If somebody say nestling, somebody can say saddling. Non-nutritive sucking, we are sometimes giving pacifier so that we are able to understand the sucking reflex, because many of the babies who delivered before 30 to 44 weeks of gestation, they are not able to develop their sucking swallowing reflex. So we are able to understand by pacifier, breastfeeding, skin to skin, massage therapy, music therapy also able to help the baby very fast. Talking about the pharmacologic pain management, where it is exactly required, where non-pharmacology, along with the non-pharmacology, we used to give the oral sucrose, best used for the heel stick, venipuncture, IM injection. There are so many studies, nursing studies are also there. When the baby having any invasive procedure, we are using oral sucrose for the baby, and that have a pain reduction for the baby. Opioid like morphine, fentanyl, Presidex and acetophenamine, these are the drugs that we can give along with the non-pharmacological management subjected is required and advised by the neonatologist. As we talked about the step 1, the mild management of the pain, we can go for the paracetamol or metazamalize. Step 2, moderate pain, we can go for the tramadol, sarcoidine. And step 3, morphine and oxygen. And step 4, the special techniques in charge of the pain units. The NSA, the painkiller management units will be taking care of the baby. NICU pain management method, as I talked about, breastfeeding, non-nutritive sucking, non-pharmacological approach, swaddling, rocking, music listening, skin to skin, and also pharmacological effect is very good. And as we talk about the infection control, as you know, the WHO is having the 6 client: clean hand, clean mother, clean delivery surfaces, clean cord cutting, clean cord tying, and clean cord care. This is one of the most important issues so that the baby should not develop any necrotizing enterocolitis and baby should not develop any umbilitis or umbilical sepsis. Policies for infections control in neonatology. All neonatology care units and staff must be familiar with the infections control protocol. Strict hand hygiene, that need not to say anything more. Invasive procedures shall be used cautiously with appropriate aseptic technique. Handling of neonates shall be minimized, as I am talking about time and again. Equipment and supplies should not be shared between infants, and visitors must be restricted, although parents can be allowed and mother is always allowed. So breast milk, no other milk, kangaroo mother care, and decrease susceptibility of the baby to infection control protocols. These are coming under the, as you know, that according to hospital's policy, we are doing changing of the tubes, cleaning of the floor 3 times in a day, and separate articles for neonates also coming as the bundles for the infections control. It is a very important issue for the respiratory care, as I'm talking about constant pressure to the airway. baby is in non-invasive respiratory support, it might happen if we need not to go for the ventilation. In that cases, we can have the two types of the ventilator support to the non-invasive ventilation support to the baby. One is bilevel positive air pressure that we can popularly know as BiPAP. And if that is not working, then we can have the continuous positive pressure airway, that's called CPAP. From there CPAP, we might have the optimized functional residual capacity. And from the BiPAP, we can have optimized functional residual capacity and support the tidal volume. So whenever baby is in NICU, we may not require always intubation, but if it is intubation not required, then baby may go for the BiPAP or CPAP support for the respiratory care. As I talked about, many may develop birth asphyxia and they can come to the NICU. Another VAP bundle we must be taking care if the baby is going to the ventilators. There are VAP bundles, as all of you know. I believe positioning guideline on re-intubations, condensation, evaluating for the hygiene, hand hygiene, everything is required so that baby cannot develop any kind of the ventilator-associated pneumonia. This slide I don't think is visible, but still is a nutshell. It is say that assessment and responding to an infant's health, expertise in nutrition, competence in medical and fluid management, expertise in supporting the growth and development of an infant, competence in procedural skill, ensuring continuity of care. All together we can say clinical competence, then only the neonatal mortality can be reduced and it will be one of the good health indicators for our country. So understanding whoever the team members will give the care to the NICU baby, they must be able to understand the specification care of the NICU. They must having the attitude and behavior to give care to the NICU because it's a very sensitive, very emotional, very compassionate care is required. So the NICU practitioner, NICU nurses, NICU all staff require very sensitive and emotional hands. Sharing the care with the family by inserting it in the NICU, seeking professional qualification to deal with the complexity of the NICU care. If we not know anything, if you have any complexity with the baby, we have to take the special support. Promoting teamwork, limits and possibilities, caring for the recursion of the premature care in critical and technological setting. We should not have any egos or should not have anything. Being a neonatal nurse, I always appreciate the staffs who having the skill and have a compassionate heart and mind to take care of the newborn. So we'll be giving promotes bonding for the mother and infant, provides nutrients, satisfies the child emotional needs, protection from diseases, supports brain and nervous system, and improve intelligence and cognitive outcome, long-term health benefits, high absorption and digestibility of the nutrients. If we go through all these things, only the newborns can be survive, can be protected, and mortality and morbidity will be reduced. So the take-home message for the newborn care and that with the evidence-based practice in NICU, breastfeeding with breastfeeding, promotion of enteral feeding if required, hygiene measures, CBC management policies, CBC bundle, inline filters, enteric microbiome should not be there, H2 blockers and steroid restrictions, antibiotics stewardship must be required for the baby and prevention of the ventilator-associated pneumonia. Apart from that, breastfeeding, kangaroo mother care, family participation is a mandatory evidence-based practice in NICU. So thank you. If you have any question, please.
Thank you, ma'am, for your highly valuable presentation. Your insights into the evidence-based neonatal nursing practices were extremely informative and inspiring. I would also like to thank the moderators for this session and all the previous sessions. Before we arrive to the concluding segment for today's webinar, we extend a sincere gratitude to all our distinguished speakers for generously sharing their expertise, knowledge, and valuable experiences with us. Today's scientific sessions have truly enriched our understanding of evidence-based nursing practice and its importance in improving patient care and healthcare quality as a whole.
Now, I respectfully invite Ms. June Datta Ma'am, Senior Nursing Officer, Department of Hospital Administration, SGPGI Lucknow, to kindly propose the vote of thanks.
Good afternoon, respected Director Sir, Honorable Medical Superintendent, Professor R. Harshvardhan Sir, and CMS sir, respected CNO madam, NC madam, and other seniors and juniors, esteemed speakers, dignitaries, members of the organizing committee, faculty members, and dear participants. On behalf of the organizing committee, I extend my heartfelt gratitude to all of you for your valuable presence and support in making this International Nursing Webinar a grand success. Our sincere thanks to Director Sir and CMS Sir and MS Sir for their constant encouragement and guidance towards nursing excellence and academic growth. We express our deep gratitude to our respected CNO Madam, NC Madam, Alka Madam, and Neelam Madam, and so others seniors for their leadership, motivation, and continuous support throughout the program. A special thanks to all our esteemed speakers for sharing their valuable knowledge, experiences, and insightful thoughts, which truly enriched today's session. I also appreciate the dedicated efforts of the organizing committee, technical team, and staffs whose hard work ensured the smooth conduct of this webinar. Finally, heartfelt thanks to all participants from different institutes for your enthusiastic participation and active involvement, which made this webinar truly meaningful and successful. Thank you once again to everyone. Have a wonderful day ahead. Now I call to our today's anchor, Mr. Abhishek Nahar,